test, check. Hello, hello, hello. 1, 2, 3, check. Check this. Hello, check. Hello, hello. 1, 2, 3, check. Hello. Check this. One, check. Hello. 1, 2, 3, check this. Hello, hello, hello. Check this. One, check, check. Second. Check. Hello. 1, 2, check. Hello. Check. Check. Check this. One. Check. Check. Check this. Hello. 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 Check. Check this. Hello. Hello. One. Check. Check. Hello. 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 Check. Check. 1, 2, 3. Hello. Hello. One. Check this. check, check. This one, check. Hello, hello. Check. This one, two, check. Hello. This check. Check, 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 check. This check. Hello.
चालू है क्या? ठीक है। हेलो। ये डैफनी मैडम है? नहीं। हाँ। बोलना पड़ेगा कि रिप्लाई सेक्रेटरी। हाँ। हाँ। डैफनी भरत जग्गे।
गणाध्यक्षाय धीमहि नमन्दिताय गुणेशानाय धीमहि गुणाधीनाय गुणाधीशाय गुणप्रविष्टाय धीमहि वक्रतुण्डाय वक्रतुण्डाय गौरीतनयाय धीमहि प्रजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Good afternoon and very warm welcome to all of you. We start this fourth Criticare Academic Convention with blessings of God Almighty and our parents. And to begin with, we remember on this occasion a very towering personality in the field of critical care medicine, a friend, philosopher and guide to most of us, Dr. Atul Kulkarni. He was there in first and second Criticare Convention. Last year, he could not come because of his illness, and then we lost him. It was a great loss to the entire medical fraternity, National ICCM, Nagpur SCCM. We all miss him a lot, and this is the tribute to him. And with this tribute and dedication of this program to Dr. Atul sir, I welcome all the distinguished faculties, Dr. Subhal Dikshit sir, who has come all the way from Pune for this program. He is past president of ICCM and past president of Indian Society of Parental and Enteral Nutrition. Dr. Bharat Jagyasi, he is past secretary of National ICCM. He has come from Navi Mumbai. Dr. Daphne ma'am has come from Apollo Chennai. She is secretary of ISPEN. And Dr. Rajdeep, who has come from Bhandara as a faculty to our program. All the delegates, my dear organizing team who has constantly worked hard for this program. And to begin with, want to thank from my heart Dr. Nikhil Balanke, who's a constant driving force for all of us, for all the support and guidance which he has provided for every year for the success of this convention. It gives us immense pleasure to have experts and enthusiasts from across the field of critical care who has come together for this nutrition workshop. And we all know that nutrition is not just a supportive treatment, it's a metabolic therapy and it's a vital therapy that influences recovery, it influences outcome in critical care. And we hope that today's scientific program will spark some meaningful discussions, practical learning and new perspectives. Wishing you all a engaging, learning, academically stimulating day ahead, and thank you all for being here. Thank you very much. With this, I invite the masters of the ceremony all throughout today and tomorrow, eminent intensivist and anesthesiologist from Criticare Hospital, Dr. Bhunika Mandal, and along with her, Dr. Shweta Kavalkar. She is senior microbiologist from Nagpur Criticare Hospital, and they will guide us all throughout this academic program today as well as tomorrow. Thank you.
Good afternoon, everyone. I am Dr. Monica.
And I am Dr. Shweta. On behalf of Dr. Deepak Jaswani and Dr. Deepti Jaswani, the entire Criticare team, we are absolutely positively thrilled to have you all here with us today.
We extend a warm welcome to our distinguished guests, our esteemed faculty, and most importantly, our colleagues joining us directly from the trenches of critical care. For the 4th Criticare Convention 2026, in collaboration with Association of Physicians of India Vidarbha Chapter and Association of Parenteral and Enteral Nutrition Nagpur Chapter, we, as in Deepak Jaswani and Dr. Deepti Jaswani, started this tradition of learning 4 years ago as an effort to enrich ourselves in the care of our patients, which is the primary goal of every doctor.
When we talk about Dr. Deepak Jaswani, the term gold standard is not just a guidelines, it's a personal obsession. He executed this ongoing convention not just as an event, but as a commitment to ongoing evaluation, where knowledge is not a secret but a shared goal.
We started this tradition in 2023 with Dr. Deepak's vision and guidance of Dr. Balanke sir, who has always been a strong support of our endeavors, and I am profoundly happy to share that we have received immense love and cooperation from all our seniors and contemporaries.
Now, before we get into heavy science of nutrition, I have to let you in a little secret. In Criticare ICU, we are the bunch of doctors, say, for example, energetic people. We are never really serious except about our patient.
But apparently our masti reached a limit. One day Deepak sir looked at us, shook his head and said, "Enough. I am giving you 2 specific topics. You have to excel in these, implement them in the ICU, and I want to see real improvements."
And where it's like, what topic and what work?
I will be frank. We really tried to crack the code on our own. We spent nights reading papers and debating protocols. But we quickly realized that everything can't be Googled. As the saying goes, मुश्किल काम में मशवरा तो हर कोई दे देता है दोस्तों, मुश्किल काम में मशवरा तो हर कोई दे देता है दोस्तों, पर तजुर्बा वही काम आता है जो बरसों की मेहनत से गहरा हुआ हो. So instead of struggling alone, we decided to bring the best experts in the country right here to Nagpur to enlighten us. And Dr. Balanke sir, as always, kept on egging Deepak sir on.
And that brings us the core of this year convention, the science of nutrition and the battle against infectious disease.
Because let's face it, in the ICU, fighting an infection without proper nutrition is like going to war in a tanker with an empty fuel tank. आवाज तो बहुत आएगी, धुआं भी निकलेगा, पर गाड़ी मेरे दोस्तों 1 इंच भी नहीं हिलेगी.
Exactly. Medicine might be a weapon, but nutrition is the true armor of a patient.
So here we are putting the masti on hold, mostly to challenge protocols, share our war stories and bridge the gap between the molecule and the bedside. But before we start our journey of advancement and evolution of science, let's ground ourselves in a tradition which is older than any ventilator or science. To light the lamp of knowledge and officially start our scientific sessions, we invite our mentor, Dr. Nikhil Balanke sir, our organizing chairman, Dr. Deepak Jaswani, our organizing secretary, Dr. Deepti Jaswani, Dr. Miraj Sheikh, who is president of IAPN Nagpur chapter, Dr. Rita Bhargav, who is secretary IAPN Nagpur chapter, and our esteemed faculties, Dr. Shubhal Dikshit, Dr. Daphne, and Dr. Bharat Jagyasi on the stage for lightning of Samai. And also Dr. Ashwini Taide, Secretary of API, Nagpur chapter.
The Dhanvantari mantra says, Om Sarve Bhavantu Sukhinah, Sarve Santu Niramayah, Sarve Bhadrani Pashyantu, Ma Kaschit Dukha Apnuyat. May all be happy, may all be free from the illness, may all see what is auspicious, may no one suffer from any disease.
Spirit of wisdom and to guide our discussions and enlightenment. They say that great things can never be done alone, and this even surely proves it, because We couldn't have achieved this synchrony without the unconditional support of the India Association of Parenteral Nutrition and Enteral Nutrition Nagpur chapter. So I request Dr. Deepak Jaswani sir to please felicitate Dr. Miraj Sheikh, President of India Association of Parenteral and Enteral Nutrition Nagpur chapter, and Dr. Rita Bhargav, Secretary, India Association for Parenteral and Enteral Nutrition Nagpur chapter. Thank you, Mirat sir. Thank you, Rita ma'am. Now that the fourth Criticare Convention is officially open, it's time to move on from the why to the how.
That's right. We are beginning at the very foundation. We can't build a house without a solid base, and you can't treat a critical patient without a solid nutritional strategy.
Our first session is designed to set the tone. We are diving straight into an overview of nutrition in critical care medicine. This isn't just about calories. It is about understanding the metabolic storm our patients face every day. For this session, I request our expert panelist, Dr. Sudhir Chafle, who is a critical care consultant at Getwell Hospital, Nagpur, Dr. Ramesh Hassani, consultant intensivist at Arihant Hospital, Nagpur, Dr. Renuka Mende, nutrition and dietitian in Nagpur, Dr. Chittaranjan Yadav, senior clinical dietitian at Max Hospital, Nagpur, to please grace their chair. To lead this vital discussion, we would like to call on Dr. Subhal Dikshit, who has extensive experience in the field of intensive care. I need not actually introduce him too much, but I'll still go on. Sir is a critical care medicine and intensivist in Sanjeevan and MGM Hospital, Pune. Sir was the past president of ICCM.
So, ladies and gentlemen, please take your notebooks, your iPads, and let's begin with our first session.
So thank you, chairpersons, and thank Dr. Nikhil Balanke, Dr. Deepak Jaswani and his team, and also the Vidarbha Association and Society of Critical Care Medicine for inviting me. And it's good to talk on nutrition, and my talk is going to be a perspective bird's eye view of what nutrition is and how it should be given. And definitely in the talks which follow me, and then we have got the workstations later, we'll be getting the hands-on experience as to when, how, and how to deliver it and what to deliver it. We'll see it over a period of time. We know that critical care nutrition is equally important. We have definitely spent time, and we see that all our patients who are admitted into the intensive are in a hypercatabolic state, and they are in a rapid state of malnourishment, and almost 50% of these patients are malnourished. We see a wide spectrum of patients, right from pancreatitis to trauma to burns to ARDS to ECMO, perforated appendix with major resections, malignancy. All these patients are in a rapid state of malnourishment. Definitely, if you don't feed these patients, they are definitely going to lose weight. They are going to lose a large amount of muscle mass. And because of that, the immune system will get suppressed, and they will lead to further length of morbidity, mortality. The length of hospital stay or the duration of mechanical ventilation will also go up into these subset of patients. So, mind you, giving nutrition prescription is equally important as much as we all intensivists and critical care experts spend time to optimize the antibiotic policies, to optimize the infection control policies, to optimize the ventilatory strategies, or how and when the dialysis prescription needs to be optimized and when the patient. So the same level of expertise and the same level of care definitely needs to be given for all these patients who are admitted into intensive care. Even Professor Jaluvi had definitely come up with a mnemonic of fast hug, and the fast hug BID, the first component F stands for feeding. So that's what is equally important, and that's what itself says that nutrition forms a very pivotal, important component of all critically ill patients. Mind you, it's not just when the patients get sick you should give nutrition, Most important, if you see the left hand side, the total cumulative calorie energy deficit plays a very important role. Be it a patients, whether you are giving nutrition, or patients not necessarily every time get admitted to the ICU. There are few subset of patients who will get admitted to the ward. There will be a fractured neck femur who is stable, who will get operated and get admitted to the ward. There will be a perforated appendix who is just been stabilized, just been in the ICU for 3-4 hours of operation and then get shifted out. These are even the subset of patients who are in a hypercatabolic state. These are also the patients who require nutrition. A fractured neck femur, if you don't feed the patients, will not have the energy to perform physiotherapy or even a knee replacement, hip replacement therapy. You need to give them proper planned nutrition, equally important. So mind you, right from the start of admission, you have to start feeding the patients, and if you find that the cumulative energy deficit goes on increasing to more than 10,000 kilocalories, then the chances of these patients landing up into sepsis or landing up into a more amount of length of hospital stay, more duration of mechanical ventilation is going to be more. Vis-a-vis, if you calculate, if the cumulative energy deficit is less than 10,000 kilocalories, then the chances of these patients being on a less number of days in ICU or mechanical ventilation. So most important is timing. The timing is equally important as much as you and we spend time, as time is myocardium, time is neurons. You see that you have got window periods for thrombolysis for the brain or stroke or heart. So same, the timing of nutrition is equally important. You have to start feeding the patients immediately on admission into the intensive care units. And I would further add, not only intensive care units, all patients, those who need nutrition, after assessment, you should start feeding them right even in the wards. And you must ensure that the demand versus supply gap does not go on increasing, and that the gap has to be narrow, so that automatically the cumulative calculative energy deficit is going to be less, and as a result of which the less morbidity, less mortality will occur in subset of patients. So the timing is very, very important. Now the impact, what I told you, it implies across a vast spectrum, be it in any speciality. It could be an orthopedic specialty, oncology, surgical, medical, hematological malignancy, even intensive care units. If you don't give, definitely there is going to be a large amount of protein loss as well as calorie loss because of the hypercatabolic state. The protein loss is going to continue, and definitely the gluconeogenesis and definitely the glycolysis is going to continue. And because of which, if you don't give adequate number of proteins, the person is going to lose almost about 800 to 900 grams of muscle mass per day, and that will give rise to poor wound healing. You will have a burst abdomens, you will have got fistulas which may be leaking. There will be patients spending more duration of mechanical ventilation or more duration of mechanical ventilation. It could be because of the lack of protein, so that the mechanics of respiration of the intercostal muscles have been weak. Along with that, trace element deficiencies can also be one of the responsible precipitant factor for those kind of delayed weaning. Definitely it will precipitate immune suppression, which will cause organ dysfunction, and that will further land up into multiple organ failure. So the timing is the most important. You should analyze and start feeding the patients as fast as possible. And definitely we have got different subset of patients, either oral, but I will not be sticking into oral in this part of the talk. We'll just be talking about enteral, parenteral, and the fancy of immunonutrition, where Bharat is going to give a separate talk, but I'll give a bird's eye view. As I said, nutrition is important, not only intensive care unit, it also will increase the length of hospital stay, also the morbidity, and also the sarcopenia, which will occur in case if you don't feed these patients. There will be weakness. The patients will not be able to do proper physiotherapy. He'll get fatigued out. He will be breathless, and definitely that can also give rise to psychological disturbances. So giving nutrition forms a very pivotal component of it, and assessment of all patients plays a very important role. Mind you, we have got different forms of formulas to assess it. We have got the Nutri-Score, which takes into consideration the seriously duration of starvation, how long has been fed, what is the seriousness of the disease, and the most important, it takes into consideration the interleukin-6, which now almost every hospital does. Mind you, it's just a marker of inflammation. So higher the Nutri-Score, more is the severity of the disease, and those are the patients who require more aggressive nutrition support. The most important form is indirect calorimetry. Yes, it tells you the resting energy consumption rate, though we have got certain ventilators which also tell you the resting energy consumption. It also tells you the amount, and separate specific machines which certain hospitals have got the luxury to use it. But definitely all other hospitals, it's not that you don't have ECMO, you can't treat the patients. Similarly, if you don't have an indirect calorimetry, doesn't mean that you can't plan your nutrition prescription. You can definitely plan with the help of other subjective global assessment. You have got the MUST, you have got ultrasound guided measurements to plan it and monitor it. And most important is the NRS one. And the recent ones which has come up into the ISPEN 2025 is the GLIM, which also plays a very important role, which definitely comes up. So mind you, it's very simple. You must have a trained dietitian in your unit. It's not just the intensivist, and there where the dietitian plays a very important pivotal role in 10 to intensive care units. Each and every dietitian definitely must be available 24/7. Definitely there are few hospitals which have got a luxury of that, having 24/7, but at least we must have a dietitian from morning 8 to evening 8, because the dietitian is the one who will be talking with the intensivist and planning the nutrition prescription. And not only just planning the prescription, their job is also to ensure that the delivery is done, and the monitoring of the nutrition is equally important. There are a lot of things which also happen dynamically into intensive care units. The patient worsens, the patient undergoes the intubation, he may be NBM for intubation, he may be also shifted to the NBM for a surgery, and definitely there is a feeding deficit which can also occur, because the normal feeding which is going to occur about 10 feed standard 150 to 200 ml starting from 8 a.m. to 10 p.m. That's what is the standard schedule which runs in majority of the ICUs. But we don't sometimes monitor that, yes, he's been NBM for 4 hours, he's been operated for 4 hours, he's gone to the OT and now has come out of the OT and is going to be NBM for the next 48 hours. So definitely the nutrition prescription has to be dynamically changed as much as you change the IV fluid protocols or the antibiotic protocols or the ventilatory strategies. You must definitely see, and you must analyze the patients within 48 hours or within 48 hours after ICU admission and have a nutrition prescription which is planned. Indirect calorimetry is the best, what I said. It's quite sensitive, specific, which is there, and it should be used whenever available. And definitely, vis-a-vis, if you compare it, the nutrition prescription will almost have a sensitivity and specificity of almost about 90% if you are using an indirect calorimetry, vis-a-vis if you are going to plan it with a GLIM or any other score in which you are comfortable. GLIM is the one which is recommended now, but if someone is comfortable to calculate it with any other form, most important is calculation. That plays a very important role as far as planning the nutrition prescription, because an ounce of prevention is better than a pound of care. Because if you don't feed, you know that there will be a protein loss, there will be muscle loss, there will be fistulas which will continue to drain, there will be burst abdomens, there will be poor wound healing, there will be impaired respiratory mechanics causing patients to be on mechanical ventilator for a prolonged period of time, and definitely the morbidity, mortality, length of hospital stay is going to go up, and importantly the cost factor will also go up because of secondary sepsis, which is also going to be. So the route of feeding, as I said, is going to be enteral. So as we definitely say that, yes, most important, you need to optimize the hemodynamic status of the patients, and the best route is enteral nutrition support is the best way after you have achieved and after you have seen that the patient's hemodynamic stability is being achieved. How will you define it? As I said, the hemodynamic stability has to be achieved once you have ensured that the fluids have been optimized, and once you have got reducing doses of vasopressors, and once you have achieved the MAP of more than 65 millimeters of mercury. That's the time when you can definitely start feeding the patient again. And definitely there is a aggressive phase, then an intensive phase, and a stability phase, and gradually how to go about, I'll definitely cover it up. It's like what we have a day of bunch. It's a cocktail of things which needs to be given. The combo pack works best as far as giving calories and proteins. Mind you, calories versus proteins. Proteins definitely predominate, and more importantly, it has to be given in the combination of carbohydrates, fats, lipids, trace elements, vitamins. All needs to be taken into consideration as what we have just had in the Bougainvillea restaurant as a complete one. And the proteins definitely should be given about 1.2 to 1.5 grams per kg of ideal body weight. There are a few subset of patients of burns, polytrauma. These are the subset of patients who will require higher proteins, about 2 grams of per day, and energy requirements about 25 to 30 kilocalories of energy, and a combination of lipids, proteins, carbohydrates needs to be given along with minerals. And using this combination works beautifully well even for a glycemic control. And another fancy of immunonutrition, where we have got a separate talk by Bharat which follows, so I won't go into the depth of it and just cover the perspective of it. The normal standard combination is about 50% of carbohydrates, then proteins about 30%, and 20% is fat. So about 50 is to 30 is to 20 is a normal composition what we give. But mind you, it's again, the concept has changed to a personalized nutrition. It's an individualized nutrition which you need to give. You need to also take into consideration the fluid status of the patient, and therefore the planning of nutrition prescription and the combination formulas may vary, and it has to be individualized and personalized, which plays a very important role. As I said, gut is most important. It's much more cheaper. Use it, otherwise you will use it, because if you don't feed it, definitely as long as the muscle atrophy will occur, similarly the villus atrophy will occur, and you lose the normal defense system and of the intestines, and that's what will cause the translocation of bacteria from the gut, with further precipitation of sepsis. So it is much more cheaper, much more physiological. It's quite easy to deliver either in the form of a continuous form or in the form of a bolus form, and this is a standard formula that once you have assessed patients who have been admitted, you should definitely start feeding them either with the help of enteral nutrition support. Yes, there have been a lot of dilemmas and discussions and papers which has come up whether a hypocaloric feed should be given. Yes, in unstable patients you can definitely start off with less number of calories and then gradually build it up. Just give about 10% to 20% till the patient is about stabilized. But once you have achieved the stability, then you should gradually build up feed and try to ensure that you reach about 80% of the caloric goal within the first 72 hours. And in case if you cannot bridge or give the deficit number of calories, that's where the role of parental nutrition will come. The concept of parental nutrition has really moved from TPN, where very a few subset of patients remain. They have moved from TPN to supplemental or partial parental nutrition support nowadays, rather than being specifically called as a TPN. Though we have got a few subset of patients and identities where TPN still plays a role. Definitely the initial concepts where the age-old surgeons is to tell us that, see, for the gastric residual volume, give test feeds. Those concepts have gone. Nowadays, normally people don't see gastric residual volume, and it really becomes a major concern. Only if you find that the GRV is more than 500 cc's, then that's the time you can reduce the rate of feeding by half and use prokinetics either in the form of metoclopramide or in the form of levosulpride, and then definitely continue to feed the patients and ensure that if you are giving feeding, then you can either convert it from a bolus to a slow continuous form of feeding. But once you are giving a slow continuous form, see that the hanging time of that feeding is not more than 6 hours to 7 hours, and in case if the hanging time is going to be more, then you need to prepare a fresh feed and give it. Mind you, if the deficit number of calories are not met, then definitely you must ensure that these deficit number of calories are being supplemented with the help of partial parental or enteral nutrition support, which the further speakers will definitely cover. So as I said, the plan is enteral. If you cannot achieve 80% of the goal, then you give them supplemental parental, partial parental nutrition support, and a few subset of patients you require total parental nutrition support, and combining or using the combination for a good synergistic symbiotic effect is much more better to reduce the morbidity as well as mortality. The few subset of patients who will really benefit from TPN, where the all-in-one or the 3-in-1 bags, which play a very important, they are extremely ulcerative colitis, Crohn's disease, or those patients of major resection of intestines which have been done in the initial stages of a small bowel transplant which has been done, or those patients who cannot consume
adequate number of calories, or he's really a surgically cachectic ill patient who has to be taken up for surgery. We really need to build up nutrition before giving him fitness for surgery. So these are the subset of patients where you need to give them TPN. Otherwise, the concept and the movement has really moved from TPN to supplemental and partial parenteral nutrition support, which is there. The glycemic control in intensive care, Greet Vandenbeck came back way back in NEGM 2001 with the tight sugar, with the nice sugar level, which were backed up again by the intensive insulin therapy. They tried to control it between 80 to 120. We from ICCM also came up for the management of dysglycemia control on those patients with enteral nutrition. And overall, all the series and all the papers have suggested that the sugar levels and even the recent surviving sepsis guidelines of 25, the ISPEN guidelines and the surgical guidelines of 2025, they have said that the sugar levels are not increased because of one of the feed. They could be done because because of the stress or because of the sepsis which is there, what is important, and the sugar level needs to be kept reasonably well under control between 140 to 170, but also ensure that the HbA1c levels of these patients are also checked up, and the HbA1c levels should be kept below 7, and at least in the guidelines what we proposed, we saw that definitely we say 4 hourly, at least 7 times a day, sugar needs to be checked up for all patients who are into intensive care unit, and definitely using short acting insulins are the form of best way to use it. There have been new concepts which have also been thought on the whether to consider to use GLP-1 analogs in obese patients so that weight loss and smooth control is just a 50-50 situation, because you are not, though you are going to use it, though definitely they are not going to lose weight immediately, but more importantly, giving a hypocaloric kind of feeding will be beneficial in these subset of patients. The guidelines have said that first achieve a hemodynamic stability. I'll just take 5-6 minutes. And there will be a hemodynamic stability that will be defined from the fluid status of the patient, that the fluid needs to be optimized, and now we have got tools to optimize and see that the fluids have been optimized, one on the basis that there is no IVC which is collapsing. You have got the leg raising test which also tells you that the fluid status has been optimized, and ensure that there is a reducing doses of vasopressors and the mean arterial pressure is above 65. In case if you start feeding, definitely it's a hypoperfused state, it's a shock state. As much as you find that the capillary leak or the capillary perfusion gets hampered, the splanchnic or the mesenteric perfusion gets hampered, and these are the subset of patients will land up into paralytic ileus. There will be abdominal bloating, and that's where you need to again reconsider your thoughts on the introduction of prokinetics once you are feeding. Severe nutrition risk has to be identified, defined that the weight loss is more than 10% to 15%, and those who have got a subjective global assessment of grade C, and the albumin levels, though the pre-albumins are much more sensitive, albumin level of less than 2.5 should be taken as a high risk marker. Here I would talk one thing, mind you, using serum albumin is a drug, and serum albumin is not a nutrition product. The indication of serum albumin has got as a nutrition product is 0 into intensive care units, and it is used only purely to increase the serum albumin levels in large volume paracentesis or in those patients with hepatic encephalopathy where definitely a liver dysfunction is there, but it should not be used as a nutrition product. So before starting nutrition, the guidelines is there. You calculate, you analyze the prescription, plan the nutrition prescription, start with the recommended levels of 25 to 30 kilocalories with 1 to 1.2 grams of per kg body weight. Try to achieve 80% of the calorie goals within the first 72 hours, and in case if you can't achieve it, supplement them with the help of partial parenteral or supplemental parenteral nutrition support. With burns, polytrauma, those patients of ECMO where there is no renal dysfunction, you need to give higher number of calories, about 2 grams of protein. And which is the best route? Yes, enteral nutrition support is the best route, though there will be a few subset of patients who will be coming out, a major Whipple's who is coming out, or a major pancreatic surgery who is coming out after necrosectomy. Those are the patients who will be moved out either with the help of a jejunal tube, or you can also use a Freca nasojejunal tube, where you can start feeding the patients in post-pyloric, where you accept that these patients are going to be of the high risk of aspiration. So these are the patients where you should start it. How you should use it, whether a bolus feeds or a continuous feeds. Yes, the guidelines, it's actually individualized. You need to personalize it using continuous feeds versus bolus feeds. Yes, some people find it that giving a continuous feeds are much more better physiological as compared to the bolus feeds. But mind you, I'm still of that thing, use it, and you must be knowing to monitor the nutrition support. That's what plays a very important role. And should exclusive all patients be given parenteral nutrition? No, all patients should not be given. So it's just a role of supplemental parenteral nutrition levels which play a very important role. The most important is the kitchen feeds. We still get relatives who come in with fruits and with kheers and X and Y and Z. It's a big no into intensive care units because our patients are in a hypercatabolic state. These patients definitely, more importantly, you must definitely use the commercially available formulas which are there. And mind you, you should always tell your sister to prepare the feeds with the scoop or the measure which is being provided by the company, because exactly then only you will know the exact number of calories and proteins which have been delivered to the patients once you have prepared the feed using it. Though we have got different now softwares which are available, we have got technologies which are also available, though you have got now artificial intelligence coming into it, but mind you, the experience and mind you, the planning of the prescription will differ. They will has to be individualized, that has to be personalized, and definitely you have to use commercially available formulas. And the reason is, one, because the bacteriological content of that is less, the osmolarity of that is of the commercially available formulas is less. They will not cause a blocking out of the Riles tube, and that will also not require a frequent changing of the tubes, and therefore using commercially available formulas should be given. Even the guidelines have recommended enteral route, use commercially available formulas, should be diverted to the lower intestinal in case where the aspiration is there, and give 80% of the caloric goals. Should all patients should be given the fancy of immunonutrition? I won't waste much time into it. It's a big no. I will wait for Bharat to cover it up into his talk. Although I'll just end up here that yes, using glutamine or using it in traumatic brain injury or in patients of burns as a drug in the first levels, provided that there is no septic shock and renal failure, but we'll definitely cover it up in detail in Bharat's talk, which is going to be followed. So use standard commercially available formulas which play a very important role. Should all, now we have got partially digested peptides. Partially digested peptides should all patients, just because the patient has got diarrhea, should be used. Mind you, not all patients' diarrhea is caused because of the feed. Rule out that you have not had an overdose of prokinetics. Rule out a Clostridium difficile infection because it's been on antibiotics for a long period of time. And yes, not all patients require, only those patients of proven malabsorption, ulcerative colitis, Crohn's disease. These are the subset of patients. Either you use the partially digested peptides or the FOS which be there. And the role of HUN therapy is again early. Give vitamin C, which came up in a big way as an anti-inflammatory. We did have omega-3 as a big way in anti-inflammatory. Use antioxidants. But yes, using trace elements as a part of supplementation plays a very important role in chronic alcoholics, where definitely there will be deficiencies of selenium and magnesium, which ultimately, and copper, which can be hindrance for delayed weaning of patients from mechanical ventilation too. And therefore, you need to supplement these patients, and giving adequate number of proteins is equally important, as much as certain importance of calories into few subset of patients. But the take home message is, you analyze all patients within the first 24 hours, plan the nutrition prescription, give enteral nutrition support to deliver 80% of the calorie goal, use supplemental parenteral nutrition support, and more importantly is deliver, plan, monitor. And the prescription should be planned by all dietitians and intensivists when the patient is going to be stabilized and is on the verge of a shift out from the intensive care unit to the ward, and also from the ward to the hospital. And definitely the dietitian team needs to keep a follow-up of at least a couple of months, at least a teleconsultation of whether the nutrition delivery is being done properly even at home, so that the reduced morbidity and mortality can occur. Thank you very much.
Thank you, Subal sir, for a very lucid questions, a very lucid and comprehensive presentation. You nicely explained about it's not about just the calories. The nutrition is about the active therapeutic management for the hypermetabolic as well as catabolic state because of the stress and hypermetabolic state because of the infection. And at proper timing, starting of proper timing of the nutrition, either enteral or parental, definitely improves, not helping the recovery as well as to decrease the mortality as well as the morbidity of the patient. Thank you very much. I think it's open for the audience.
Sir, what is your sir, here only. So what is your prokinetic of choice, especially in those patients who are a little drowsy in ICUs? And what should be the duration?
Levosulfide is quite okay.
And what should be duration?
Though metoclopramide only because of drowsiness, certain people fear about EPS, extrapyramidal, but you can use levosulfide, which is there. Though erythromycin is also recommended, but nowadays we don't get IV erythromycin. I was in Calcutta last week and they said that they have got IV erythromycin. I was quite surprised.
And what about etopride, sir? Is it oral?
You can use it.
You can use it.
No problem.
Dikshit,
Thank
for
you.
the masterful bird's eye view, it's sobering reminder that while we are busy fighting the micro battle of organ failure, the micro battle of metabolism is ultimately decide the winner. Now I request Dr. Balankhe sir to felicitate our chairperson and our speaker, Dr. Subal Dikshit.
Sir, chairperson.
Chairperson.
ए जाओ ना जल्दी जल्दी, चारों वही है क्या? मैं चालू कर दूं क्या रे? मूविंग फॉरवर्ड. Moving forward, it's time to stop looking at nutrition as just support and start looking at it as a science. But let's be honest, between macros, micros, gastric residuals, and metabolic rates, it can feel like we're trying to crack a secret code.
And that is exactly why our next speaker, Dr. Daphne Lovesley, is here to help us make sense of math and medicine. It's about moving past routine and orders and moving towards precision feeding. It's time to decide the formulas and the timing of the change for outcomes. For this session, I would like to invite the experts in the field of chairperson, Dr. Meenal Bhuer, Dr. Ajay Bulle sir, and Dr. Kaustubh Upadhyay. Dr. Meenal Bhuer is consultant dietitian and weight loss expert at Iravio Clinic, Nagpur. Dr. Ajay Bulle, consultant physician and intensivist at KIMS Kingsway, Nagpur. Dr. Kaustubh Upadhyay, consultant physician at Shri Bhavani Hospital and Research Center, Nagpur.
For this session, Dr. Daphne Lovesley is here to take us beyond the basics with her talk, Decoding Nutrition in Critically Ill Patient. If I may say so, ma'am, Daphne Lovesley is a lovely name. Ma'am is the Chief Dietitian and Head, Department of Dietetics in Apollo Hospital, Chennai. Over to you, ma'am.
Thank you so much for the lovely introduction. And thank you, Dr. Deepak, for the invite. It's indeed a pleasure to be here, first time in Nagpur. So I'm going to talk to you on decoding nutritional status. Dr. Subal did take us through the whole picture. I am a little stuck now as to how should I be proceeding. So, this is what I have planned in my talk. These are my objectives. And when we talk about nutritional status, malnutrition in hospital has been documented, way back 1936, to be very precise, by a surgeon. But the hallmark paper was the skeleton in the hospital closet. This was in 1974 by Butterworth. But later, you do see a series of paper, 2015, 2018, why is the skeleton still in the hospital closet? So, do we all look at our patients this way? Yes, of course, till date, 2026, we do see our patients, as skeletons only. Malnutrition incidence in hospital is more than 50%. And the worst case scenario that we see is the critical illness, right? Where critical care illness is characterized by stress-induced catabolism, which includes stress hormones, inflammatory cytokines, and other mediators, especially in the first acute phase. When you look at the patient, there is increased catabolism, and this in turn leads to poor outcome, which is associated with inflammation generated by critical illness that leads to deterioration of nutritional status and malnutrition. So when we look at a patient, if they are with you for more than 2 days in the ICU, take it from me, he is already malnourished. So we do talk a lot of, tools. Yes, that is a process that we have to see, but consider them at risk of malnutrition. So what is the percentage of patients in ICU who are malnourished? It's about 38 to 78%, and it leads to increased morbidity and mortality. Morbidity per se, infection increases, complications increase, convalescence increases, very poor wound healing when it comes to surgical patients. This in turn leads to treatment duration increase, cost of the treatment. It becomes a huge bomb if one patient stays 1 or 2 days extra in the ICU, and the quality of life becomes very poor. Are we really, making our patients victims or survivors? That is a big question for all the intensivists. Yes, they really challenge with the lives of the patient, but when it comes to the outcome, it takes a long period of time for the patient to recover. So early identification is very, very important. There's a huge burden. When we talk about critical care, sepsis is one of the top-notch number, right? It's about 50% globally if you look at, and malnutrition also is in par. And in Indian setting, it is approximately 40% of our ICU patients are malnourished. Asian data also says 28 to 100% are malnourished, but when you look at an average, it's about 40%, which leads to poor clinical outcome. So malnutrition and muscle loss in critical illness is interrelated. I can tell you, as a very small intern, I wouldn't have looked at my patient the way I look at them now, but there's a lot of importance to muscle loss is given in the past nearly a decade or so. There's a lot of research happening. And who are your patients? They are patients who are with chronic disease. Most of them are aged patients, those who are already at risk of malnutrition, those who are frail are only coming into your system, right? They come with sepsis or ARDS or trauma, which requires ventilation and in turn leads to stress, inflammatory response, medication, immobilization, iatrogenic undernutrition. All these together leads to hypermetabolism, increased catabolism, and ICU acquired weakness. This is a terminology which is really spoken a lot of late. It's not about the first phase of illness that you look at. It is about the different phases of critical illness that you need to look at, and this also plays a vital role. When a patient comes into your ICU, with all these playing a role, the patient becomes weak, frail, right? Leading to malnutrition. And this is one of the latest paper. Last month it was published. Very beautiful paper. If in case you get a chance, you should read this paper. There's a lot of inputs given about the different phases of critical illness, how to handle, what kind of tools to use, when to use. Very explicitly they have explained in this narrative. And you do find during the ICU stay, there is undernutrition, there is inflammation, anabolic stress, as well as all these in turn leads to loss of skeletal muscle mass. That in turn leads to malnutrition, ICU acquired weakness, sarcopenia, frailty. They are not able to get out of the bed when you discharge them, right? That is the status they are in. And most of them don't even go back home. They go to a rehab center. And why this happens is because of post-intensive care syndrome, which incorporates all these components: physical impairment, mental disorders, cognitive impairments. And, the pathway for all this starts from the initial insult the patient undergoes. And this is a beautiful, tabulation which really clearly speaks about defining each of these components and different tools that can be used and the incidence. You do find malnutrition in up to 50% of the population, ICU acquired weakness up to 60%, sarcopenia 10 to 20%. Especially it is higher in older patients, and frailty about 40% of the ICU patients, have incidence of frailty. Why does this occur? Yes, we do get patients who undergo surgery or they come with trauma or any kind of critical illness leading to inflammatory response wherein there is increased IL-1, IL-6 or tumor necrotizing factor. There is an increase wherein you do find neuroendocrine response leading to increased cortisol, glycagon and catecholamine leading to muscle loss. This is what we see. Many times we do not correlate all these components. Individually we act upon, but finally you will see a skeleton in the bed. So, why does this happen and why should we be really worried? Because sarcopenia as an independent factor predicts morbidity and mortality in critical illness, and it is correlated. This is a very beautiful paper wherein they correlate this with the organ failure, whether it is single organ or multi-organ. You do find a drastic difference as the number of organ failures increase. 2 to 3 and 4 to 6, you do find that there is a steep decline in the muscle mass, and you find that it is 17% of muscle loss in about 10 days. That is the first phase of critical illness, right? So much of change occurs, but does that mean the calorie and protein that you give is going to make a big difference? Yes, of course it does. But it has to be personalized, as Dr. Dikshit told us. It has to be gradual. There is a lot of work going on in this aspect, and you do find a lot of latest papers speaking about progressive nutrition. Nobody speaks about overfeeding now. I can tell you, as a little dietitian, when I started my career 30 years back, we used to prescription is equal to what is provided. That's how we used to run the show, right? Because we didn't have an understanding as to how to process it. Okay, 1500 calories is being prescribed. I will ensure that I give 1500 calories, if that is the goal. But of late, there are so many researchers which have proven the other way. Coming back to sarcopenia, when we talk about sarcopenia, as there is gradual decline in the muscle mass, you do find there is, it affects immunity, it increases the risk of infection, slows down your wound healing, And when it is above 40%, the risk of mortality also increases. And this systemic review clearly, shows that there is 2.2-fold increase in mortality between a person with sarcopenia and without sarcopenia. Are we assessing sarcopenia is a question that you should be, rattling in your mind, because many a times we don't. And ICU acquired weakness, 1 out of 4 patients have ICU acquired weakness, and that in turn leads to short-term and long-term complications, including increased mortality, length of stay, and increased ventilation. Extubation becomes a problem if somebody doesn't have enough muscle. And long-term per se, they don't go back to their home. They go back to a next hospital or a rehab center. So they stay for a long period of time in hospitals, and malnutrition by itself has an impact on infection, intestinal dysfunction. This is one important thing. Doctor did speak about GI distress, when to pick up, when to change your feeds. I can tell you at least 50% of your ICU population will have some percentage of GI distress. So it is so important for you to understand and change the feed accordingly, because this also leads to altered muscle function, because absorption may be less. They may not be feeding enough. So you should have a process in place. This is a JCI, algorithm what they have given. On admission of any patient, you need to screen the patient, assess the patient if they are at risk, and make sure you make a care plan, monitor, and ensure that there is the efficacy of what you do is understood, and continue therapy or terminate therapy if you have achieved your goal. And early nutrition risk screening and assessment is very, very important in order to understand the risk of malnutrition in your patient. These are some of the tools available, or it could be your own institutional tool that you can use if it is validated. And you do have a lot of assessment tools available, but I'm going to really focus on GLIM today, because most of it you would have used. GLIM is one thing globally people want to use. This is what we currently use, Modified Subjective Global Assessment. We had validated this, and it works quite well, but the issue is you do have issues with anthropometry, because these patients have fluid overload, they are not mobile, and they are in acute illness, right? It is very difficult to collect information, collect things, but I tell you, the next level you have to think of is GLIM. Before that, Nutrix score. How many of you do Nutrix score? I think we can have a dialogue henceforth. No, I can tell you it is one of the toughest thing to do, because we have done a study where we compared SGA with Nutrix score. It is pretty laborious, that's what we felt, and we didn't find any major change between Nutric and SGA. SGA might take us few minutes to do, but Nutric score is a laborious process, because you need to collect so much of data and then come to a conclusion. And are we really aggressively feeding the patient off late is a question to be answered. And GLIM is a tool which I would encourage all the dietitians here and clinicians to adapt, because globally they want only one tool to be used, and that is GLIM. GLIM has a framework of phenotypic and etiologic criteria. They want to have a uniform way of assessing, and whenever we collect data also, it becomes easy to collate and provide data. And it is validated in critical care, and it has been published. And first thing is etiologic criteria, wherein you need to look at how much of intake he had prior to admission. If it is less than 50% in the first 1 week of admission, prior to admission, or little reduction, suboptimal in the last 2 weeks, you should count it as, yes, it is positive. Next comes inflammation. So inflammation is one component I don't think we really relate to when it comes to assessing a patient. But GLIM has a particular component wherein it has to be assessed because in critical illness, it has an impact on anorexia, it alters metabolism, it elevates the resting energy expenditure and blunts the response to nutrition intervention. So it is very difficult. That's why, when they collect the data, even if there is a positive impact from nutrition, many a times it's not really considered. And how do we understand inflammation? It is very, very clearly provided in the guidelines what they have given. And I can tell you, all your patients who are in your critical setting, like burns or abdominal surgery or sepsis, they all fall into severe inflammation. Mild to moderate, it could be cystic fibrosis, COPD. They've given you different categories, and those without inflammation or those with depressive spells or anorexia, or it could be starvation related. And this is how you categorize the three. And severe inflammation is critical illness, burns, trauma, and major surgeries. The next component is the phenotypic criteria, where you look at the unintentional weight loss, more than 5% in first 6 months or more than 10% in more than or beyond 6 months. Low BMI, if it is less than 18.5 for Asian population, and low muscle mass. Two important components which are included into GLIM. One is inflammation, second one is muscle mass. So how do we assess it? They've given a lot of papers, validated papers to showcase that. But I tell you, you don't have to have a CT or MRI or BIA in order to have this done. These are high-end technical stuff. Yes, possible. If in case it's a surgical patient, he is undergoing CT, maybe you can do a psoas muscle to understand the muscle mass. And BIA, yes. How many of you use BIA? Bioelectric impedance? 2 minutes more? Okay. So, these are available and they do give you cutoffs for it to understand the appendicular skeletal muscle mass. For men and women, the cutoff is different. We have introduced this in our system. It's a very simple tool. I tell you, it takes only, the measurement part takes hardly 1 minute. Overall, it may be 3 to 4 minutes to complete, and dietitians don't have to depend on clinicians to do this test, unlike a CT or MRI. And this is how the report will come. It will clearly give you a picture on appendicular skeletal muscle mass, and fat-free mass index also can be done. Apart from that, face angle will also be provided. And if you don't have any high-end or fancy gadgets, anthropometry comes in handy. So calf circumference or mid-arm circumference can also be assessed, or if you don't have anything, nutrition focused physical examination is suffice. You look at their temple, clavicles, or you can really assess them looking at a patient, feeling their muscles. You will be able to clearly say. And if you're doing a calf measurement, you have clear gradings here. You can use this. This can be adjusted for BMI. And if a patient is moving out of ICU, you can think of doing hand grip strength, which is a very simple tool, but it gives a clear picture about the muscle strength of the patient. And when we put everything together, you do your screening, you do your assessment with whatever tool you're doing, then come put all the components together into the GLIM criteria, finally grade it as moderately malnourished or severely malnourished according to this grading. And this is a table that gives you all the components what I discussed with the do's and don'ts and where to perform, when to perform. And moving on, I might take 2 minutes. Okay. Phase adapted personalized strategy. This is a very important thing that you should understand. And this, they relate it with the inflammation of the patient. If the inflammation is high, You either put a stop to your feeding or you start minimally, and once inflammation is resolved, you improve on the feeding. The green arrows are increase, the red arrows are decrease. So you correlate it with the current status of the patient, inflammatory status, metabolic status, micronutrient status, and ready for feeding. So you need to put all these together and then think of feeding the patient. These are some of the biomarkers that you can look at, and different time periods when you can have a look is given there. And for all this, you require a team. Yes or no? A dietitian can't do everything together. A clinician can't do everything together. A nutrition support team is a mandate in every ICU, because only when we work together will be able to achieve what we aim for. We think very high. If you don't have the system in place, nothing works. So this is my experience. Just a minute, I'll just give a brief. This is a steering committee that we had introduced in our system way back in 2021 when we did a malnutrition awareness program in the hospital. Somehow, some dialogue, we came to know, we wanted to understand the gap in our nutrition practice. So there was genesis of a nutrition nurse who becomes one single point of contact for us across the hospital. Wherever there is issue, she will take the lead to convey the message. And then we formed the nutrition steering committee in February 2022. And we do a thorough audit of prescription to provision across the hospital. And all the consultants are part of the team. And every quarter we meet and we do update them on the functioning of the whole department. And these are the 10 indicators that we present to them. In that, you will have the calorie and protein achieved in critical care, and post-op, post-discharge. Patients who discharge on enteral and parenteral, we follow up back home as it was discussed before. We do follow up and give them a helping hand, because many times once they get out of the system, they are lost. So we do have a follow-up which really makes a very good practice for us. The take-home message is malnutrition is very common in critical care but often underdiagnosed. Inflammation drives metabolic changes. Validated assessment tools are required. Lean body mass is the key, so make sure you assess on admission and at different frequencies. Every week, 21 days, post ICU and during discharge. And for all this to happen, a multidisciplinary approach or a NST is required. Unless we all come together, whatever I spoke cannot come into practice. Team-based care is the foundation of effective nutrition delivery. Thank you for your patient listening.
Thank you, Dr. Daphne, for insightful talk. Any questions? Thank you, Dr. Daphne.
Ma'am, how do you assess the diaphragmatic strength in your ICU? And do you regularly use POCUS for that, for assessing the diaphragmatic strength?
In post ICU, you can measure it with muscle strength, because when you talk about practice, you can't always think of high-end techniques to be used. Hand grip strength and all, post ICU if you use, you'll be able to very well correlate their muscle strength, and that relates to sarcopenia. May not be a proxy, but before even somebody has muscle loss, their muscle strength comes down. That's why there's a lot of importance given to hand grip strength, even in the Asian working group of sarcopenia. The grading that they have given to HGS is better than other parameters that they look at.
Any more questions from audience? So, fantastic talk, ma'am.
One question from me.
Yes, sir, please.
Ma'am, you said subjective global assessment tool you are using usually. I feel except the IL-6 component in Nucleus score, the remaining SOFA, Apache, comorbidities, they can be very well asked and written in the score.
Yeah.
If you remove IL-6, Nucleus score is a very good score. And I have all the mutations are doing it.
Yes, of course. It is little laborious. That's what I said. We had done it also. And in our study, we didn't find major difference between Nutrix score and SGA. So what we concluded was, whoever is malnourished in SGA, we would do a Nutrix to understand how aggressive our therapy should be. And whenever we talk about aggressive therapy, of late, we don't encourage aggressive therapy in the acute phase. Especially in the first 48 hours, overfeeding has to be avoided. Okay, less than 50%. First day, 25%. Next day, 50%. Third day, 75%. Fourth day, if you're not able to really improve on his intake, if it is less than 60%, then think of partial parenteral nutrition. Because there are a lot of papers which has made it very clear, aggressive feeding in the initial phase is not required because it gives a very poor outcome.
Thank you, ma'am.
Thank you, Dr. Daphne. That was incredible. I feel like we just upgraded from paper map to a high definition GPS for patients' metabolism. Now I would like to invite Dr. Deepak sir to please present our speaker, Dr. Daphne, and our expert panelist with a token of our gratitude. We have talked about the science, we have decoded the math, but every intensivist knows the real battle isn't fought on a calculator, it is fought at the bedside.
Exactly. Theory is great, but bedside reality is where the magic or the mess happen. To guide us through the practicalities, we have someone who is true expert at navigating these ICU waiters.
But first, we would like to invite our expert panelist for this session, our own Dr. Sanjeev Bass. He is a consultant critical care medicine in Viveka Hospital. Dr. Miraj Sheikh, we all know him, consultant physician and diabetologist at Care Hospital. Dr. Prachi Wagmare, senior dietitian at Care Hospital. And now, please welcome Dr. Rajdeep Chaudhary, who is here to enlighten us on enteral feeding, a bedside approach, but in simple language to take the complexity out of the journals and bring solutions straight to the patient's pillow. Dr. Rajdeep is a consultant physician with special interest in and experience in diabetology and critical care medicine. He is running a huge hospital in Bhandara. He is the managing director of his own hospital. The diocese is yours, Dr. Rajdeep.
Thank you, Monica. First of all, thank you, Jaswani sir and Criticare team for giving me this opportunity. हॉस्पिटल बड़ा है बट प्रैक्टिस छोटी है मोनिका. एक सेमी अर्बन सेटिंग में काम करता हूँ और आज कोशिश करूंगा कि मेरे टॉपिक से जस्टिस करूँ. थैंक यू वेरी मच. So we will start. Already many points are covered, but I will stick to my presentation. So we need to feed the gut, not just the patient. An unfed gut atrophies, leaks, and stop protecting the host. Enteral feeding is therapy for the gut itself, not only the route for calories. Because it maintains the mucosal barrier. It enhances the immune signaling. It maintains the microbiome of the gut, which are very important to reduce bacterial translocation, They are the gut-associated lymphoid tissue is a very important immune organ of the body, and the microbiome preservation is very important for avoiding antibiotic-related associated complications. Early enteral nutrition reduces infection and shortens hospital stay. This has been very well proved by the many meta-analyses of many randomized control studies. You require a team, as madam said, so there will be an intensivist in the team. There will be a clinical dietitian who will be looking into the clinical part of treatment also. There will be a nutrition nurse. There will be a fellow from service industry like canteen who will be maintaining the hygiene and the quality of the feed. So the team is very important. Once your team is ready, then on the routine bedside rounds, besides your patient, you need to ask these 6 questions to devise your feeding plan. When should I feed this patient? What are the risks? Whether we should really start the feeding? What are the indications? And what are the absolute and relative contraindications? What is second question? When to start? What's the best time window for feeding these patients? Third will be, what is the route? Which tube? Through which cavity? How to do it? What needs to be avoided? What complication needs to be looked for is also important. Then comes fourth question. What formula? Standard formula, any default formula, or there are any specialized formulas? Also, the next fifth question will be, how much calories are to be given? One will be a default preparation, and other there will be a, depending on the patient substrate, there will be the other feeding formulas and their quantity. And last but not the least, watch for what? You should watch for whether the patient is tolerating feeds and whether there are any routine complications, which we will discuss in detail. So the first question, should I feed this patient? He is in ICU, he is on ventilator, he is receiving 2-3 vasopressor drug, he is on a CRRT treatment. So he is a very complex patient where all the parameters are disturbed. So what ideally bedside parameters which will be guiding us? So there are this NRS 2002, MUST and Nutric. I will just give in brief about, I will just discuss in brief about Nutric. There is a modified Nutric score now which disregards IL-6 and it takes into variables age, Apache 2, SOFA, number of comorbidities, days from hospital to ICU admission and interleukin 6 level. But IL-6 is not in the modified Nutric score. Any score above 5 is a clear-cut indication to start enteral nutrition. Other high-risk nutritional risk patients whom we should be considering early for enteral nutrition are where there is a more than 5% weight loss in last 1 to 3 months, the BMI is less than 18.5, the reduced oral intake is more than 5 days, which is the less than 60% of the estimated needs of the patient, and per se the critical illness which has brought this patient to ICU because its metabolic demands has increased. So these were the indications. Now when the gut says no, you also need to know this. There are absolute and there are relative contraindications. These 3 patterns explain how to approach which patient will be more harmful if you start enteral nutrition. The first and the foremost, mechanical, if this path is blocked or breached. If there is a bowel obstruction, there is intestinal ischemia or high output fistula without distal access. Perfusion. If gut is hypoperfused, this is the real scenario in our ICU. The absolute contraindication is severe shock, unresponsive to resuscitation. Relative ones are high dose vasopressors and active GI bleed. Inflammation per se, which is also very common ICU issue. Severe pancreatitis with instability or necrosis, persistent intolerance despite giving prokinetics. Your high GRV volumes in spite of giving metoclopramide and your other drugs, etopride and leosulfuride, if you are having persistent intolerance, then you need to think about giving continuing feeds in this patient. So, but the bottom line is relative contraindication call for judgment, not refusal. Often the right answer is to delay, not to abandon. So, approaching the bedside decision to initiate the feed or not, is the gut working? Yes, continue. No, hold nutrition, reassess after a few hours, or if it is taking more than 48 hours, consider parenteral nutrition. Can they eat enough by mouth in next 5 to 7 days? Yes, then encourage oral intake rather than enteral nutrition. If no, then continue enteral nutrition. Are they hemodynamically stable? Yes. Start enteral nutrition within 24 to 48 hours. No, resuscitate first, then also start trophic feeds. We will come in detail for that, trophic feeds when stable. So now the question second, what is the time frame or the window where we need to start the enteral nutrition? It has been found mucosal atrophy begins within days of fasting. So ideal window is 24 to 48 hours. It preserves the intestinal barrier, sustains the gut associated lymphoid tissue, reduces infection. This already we have seen. If you are not able to give total dose, full dose of enteral nutrition also, feed of around 10 to 20 ml per hour at spaced intervals preserves the gut even when full nutrition isn't yet possible. So even if your patient is in persistent shock, you can consider trophic feeding in this patient. So I have made a little bit a traffic light framework like one slide where when it's absolute green, go, safe to feed, vasopressor dose are stable or weaning, single vasopressor at low moderate dose, your NORAD requirement is less than 0.25 mics per kg per minute, your lactate is less than 2, your MAP is more than 65 and there are no abdominal signs. This is the absolute go for enteral nutrition. Then wait, continue with trophic feeding, yellow light, where your norepinephrine requirement is around 0.25 to 0.5 mics per kg per minute. Your patient is on 2 vasopressors, but the dose are stable. The dose has recently increased, but now it has stabilized. The lactate is around 2 to 4. There is mild abdominal distension and the MAP is borderline between 60 to 65. So this is a go ahead for a trophic feeding, low volume feeding, low calorie feeding. Absolute no, red, vasopressor dose are actively escalating. NORAD requirement is more than 0.5. More than 3 vasopressor, specifically if vasopressor is on, lactate more than 4. Bowel ischemia, you are finding signs of NOMI, non-occlusive mesenteric ischemia. It's a entity in critical care, specifically in post-cardiac bypass surgery patients, and active GI bleeding. So here you need to hold your enteral nutrition, you need to review your patient, and if still the hold up is for more than 48 hours, you need to consider parenteral nutrition. So now the third question, where the tube goes, what are the modes through which you will give your enteral nutrition. So match the route to the duration. For example, your patient is going to stay in the ICU for less than 4 weeks or more than 4 weeks. So if less than 4 weeks, your patient will be helped with nasogastric tube, which is a default mostly, the size of around 10 to 12 French. If your patient cannot, if your patient is having gastroparesis or there is risk of aspiration pneumonia, then nasoduodenal or nasojejunal tube can help. In case of a facial injury or massive head trauma, you can go for orogastric tube. If your patient is expected to stay more than 4 to 6 weeks, many neurological illness patient, they stay in ICU for long term, then your PEG tube, extension of PEG tube like PEG and jejunal extension, or if PEG tube is not possible, then surgical gastrojejunostomy is a feasible alternative for PEG tube. Pyloric feeding per se doesn't prevent aspiration pneumonia. It is only in those special scenarios where we have discussed gastroparesis and for example severe acute pancreatitis patient where this can help. Not per se every patient can be helped to prevent aspiration pneumonia if you are using a post pyloric feeding. So placing an NG tube, it's very basic, but we should be knowing this. Select the ideal size, ideally 10 to 12 French for most adults. Measure the distance. It is from nose to earlobe to xiphoid process. Add 5 centimeters to it, and your Riles tube will be in a proper position. Lubricate it while giving into a conscious patient. Swallowing mechanism while putting a tube helps a lot. Radiography is gold standard. Don't rely on that test bedside that your tube is in place. Radiography is gold standard. Your feeding should start only after you have confirmed radiographically that your Riles tube is in position. Secure the tube. Mark daily the nasal exit site of the tube. It is very important for your daily rounds. Here you can see the properly placed tube on the right hand side, and it is properly going through the esophagus and in the stomach. And in the next X-ray, you are seeing a tube which is placed in right main bronchus, and it has caused aspiration pneumonia. So now the question fourth, Now the fourth question we need to answer is what goes through these tubes. So basically there is a ideal situation is a standard polymeric formula which feeds most patient. The calorie density is around 1 to 1.5 kilocal per ml. Osmolality is around 300 to 500. Proteins are around 20% of the total calories. Fats are around 25 to 40%, and carbs are around 45 to 60%. The common available formulation with us are Ensure and Nutrain, which we can easily get in Indian setup. When standard isn't enough, specialized situations, for example, if there is a higher catabolic states, wounds and burns, there you need to give a high protein formulation. Such formulations are Replete or Promote. If your patient is on CRRT or a continuous hemodialysis support, then your volume and electrolyte restriction matters. In such patient, there are special feeds that are available, Nepro and Suplina. Hepatic patients will be intolerant to amino acids. So there are branch and amino acids which are NutriHep preparations like NutriHep. Pulmonary diabetic patients will be on a low carb diet. Glucerna is one of the alternative for diabetic patients. Semi-digested food or elemental foods. Pancreatic insufficiency is a very troublesome patients which we face in ICU. So such patients are supposed to be given either a semi-digested feeds or a complete amino acid fully digested food. Fully digested food are very costly, but the semi-digested food like peptamine can be given in patients of pancreatic insufficiency. So now how to question 5 calories, how to go ahead. First and foremost, the basic dictum is underfeed early and then advance into recovery. Acute phase, say within first 1 to 7 days, your calorie requirement should be around 15 to 20 kilocalories per kg per day. Depending on your patient's response and whatever assessment we have seen, those traffic indicators, you are supposed to gradually go on increasing your caloric requirement. So your optimal goal will be around 25 to 30 kilocalories per kg per day. After achieving the hemodynamic and inflammatory stability, climb steadily towards that full target. If your patient is having BMI of less than 30, then use the actual body weight to calculate this dose. And if your patient is having BMI more than 30, then adjusted body weight is the thing which should be taken into consideration while energy expenditure calculations. Proteins matter more than calories. We already discussed this. Routine is 1.2 to 2, and mostly other situations you are supposed to give a little bit higher protein concentration. One thing to be remembered in ICU in regarding CRRT patients is so-called citrate calories. These are hidden calories. While doing CRRT, these hidden calories are given by citrate fluid, and this is around 200 to 400 calories routinely in single day in a patient on CRRT. Some patients who are on high dose CRRT may also get 1000, almost near 1000 kilocalories per day from these hidden calories. So your nutritionist or your dietitian needs to adjust their formula feeds for these hidden calories which already patient is receiving from that CRRT fluid. Start low, advance steadily. This is very important because there is in Indian setup specifically where we get our routine patients who are in our ICU are either alcoholic or chronically malnourished, or they have many comorbidities. So there is a very big risk of refeeding syndrome. So this refeeding trap is what exactly? When a BMI is less than 18.5, your weight loss is more than 10% in last 3 to 6 months. Your minimal intake is less than is more than 5 days. Patient is having comorbid like alcohol use and chronic malnutrition. What happens is with the use of routine formula feeds, because of carbohydrate ingestion, the insulin surge happens. All the important minerals, phosphate, potassium, magnesium, they move intracellularly, and there can be a catastrophe in the ICU. Patient may suddenly collapse. thiamine deficiency appears and it can cause glycolysis, and there are, you see, multi-system collapse of the patient. So basically, in such category of patients, your goal should be go slow, climb up slowly, start at around 5 to 10 kilocal kg per day. That is around roughly around 25% of the adjusted body weight adjusted goal. Advance over 3 to 5 days slowly. Replete electrolytes before and during feed, specifically phosphates and magnesium, and thiamine should be an add-on for first 3 to 5 days. If you see phosphate drop after, and one more point, this is generally misleading. This refeeding trap, when it happens, your electrolyte levels on the blood parameters, they are normal. They are normal mostly. So that this shift is happening at intracellular level. So you need to be constantly watchful. You cannot just rely on your blood investigation reports for picking up this refeeding trap. You need to be clearly watchful for your high-risk patients, how they are behaving, and a daily phosphate level in such patients is indicated. Feeding methods, continuous is not physiologic, but it is best in our ICU patients because it reduces the risk of aspiration pneumonia, and in patients with delayed gastric emptying, it is beneficial. Intermittent bolus is more physiologic, and in a resource limited settings of like ours, we do practice this intermittent or bolus therapy with not formula feeds, with kitchen feeds. Touch wood, till date, we are getting good results. We are ventilating patients for 15 days, 20 days, and we are getting good results on this intermittent and bolus therapy. Cyclic is basically for patient when your patient is recovering and you are now trying this patient to move out of ICU, trying to start oral feeds. So a combination of enteral nutrition and oral feeds will be in the cyclic this method. So basically, now about the complication, what to watch for. Daily questions at the bedside. These 4 questions your team should ask. Is the 4 or 5 minutes? Yeah. Is your gut tolerating the feeds? It will be indicated by distension, stool pattern, gastric residual volume. This was a big thing few years back. Now it has gone into disrepute. Only if GRV is more than 500 ml, then only you need to think about stopping the feed. In that also you need to reassess your all therapy and again come back to it in next 4 to 6 hours if you can start your feeding. So GRV more than 500 ml is only indication to stop your feeding. Are electrolytes safe? Your potassium, your magnesium, your phosphate, your calcium, they are all important. You need to monitor them in where your patient is at the risk of refeeding trap. There, these investigations are to be done daily. Is your glucose controlled around 140 to 180 mics per deciliter? Then your therapy needs to be targeted as per your ICU protocol. Is your weight trending right? It's a very difficult thing, trending the weight. Daily weight means rather than a number, how it is trending is important because the fluid overload thing, and you need to adjust your formula and liquid component of that on this weight trending. So there are mainly 3 problems, and which we see what to watch for us: aspiration, diarrhea, and tube obstruction. For aspiration, to prevent aspiration, the dictum is elevate your head end of the bed, continuous and not bolus feed in the ICU, post-pyloric, putting a post-pyloric tube if your patient is at high risk like gastroparesis and other things. Diarrhea is a big problem in enteral nutrition. You need to rule out infection first, rule out your Clostridium difficile infection. Other things like antibiotics, feeds containing sorbitol. In such patient, remedic measures may be giving a fiber-enriched formula, and only when you are ruled out infection, then only you can give the antidiarrheals. Tube obstruction is a very common thing, specifically when you are using many drugs along with your feeding. Tube obstruction is a common thing to happen. Flush your tube 30 ml every 4 to 6 hourly. Flush each and after, before giving and after giving each and every medication. Do consider this flushing fluid in your daily nutrition chart because this fluid in my cardiac patient, in my renal patient, will this 25-50 ml will also matter. So, and use liquid formulations. So medication through tube, there are few things will go which will help us to give medicine properly and avoid the clogging of tube. Always use liquid formulation, crush your tablets to fine powder, flush, we have seen that, administer the medication separately, not mix. Hold the feeds 30 minutes around acid dependent drugs. Few drugs which are to be specially mentioned, phenytoin, fluoroquinolones, they are to be given, your feeds are need to be hold before and after giving the food. Warfarin, you need to check your INR before giving the continuous feed. Also in between, when you are giving enteral nutrition to this patient, your INR is maintained or not. PPI should be given either by suspension or they should be dissolved in soda bicarb. We have discussed this. So basically, my take-home message will be what to remember. Again, 6 points. Screen on day 1 whether your patient really requires enteral nutrition, whether there are any absolute contraindication, relative contraindication. Feed if your signal is green or amber. Feed within first 24 to 48 hours. If the gut works, then the patient is stable. Your default to polymeric formula is the go ahead in this situation. Specialized formula for specialized situation. While feeding, your calorie requirement will be underfeed early. Let your patient stabilize and then slowly escalate to the full dose in next 5 to 6 days. Slow advancement protocol avoids the risk of refeeding syndrome, which is a very big threat to our patient. And watch the patient, not the rate. Tolerance and electrolytes lead the daily plan, not your targets of calorie and all those things. So tolerance and electrolyte do matter. Thank you very much.
Did a good deliberation, Dr. Rajdeep. I just want to know how frequently do you monitor and how do you maintain those glycemic controls in those patients who are on continuous feed?
We are doing, sir, ideally 4 hourly or 6 hourly, depending upon our patient's clinical stable status. Ideally 4 to 6 hourly, sir. If the sugars are continuously higher side, we do it 4 hourly, and if they are controlled, then 6 hourly, sir. And once your patient is stable and he is not diabetic, you can do it once daily also. Once your patient is stable, he is on oral feeding.
Any more questions from the audience?
Yeah, excellent talk. You have covered everything exhaustively, except a few comments which I want to make for our dietitian friends. Do not withhold feeding in any circumstances unless patient is emergently going for a surgical procedure, even not for tracheostomy. We can feed the patients in prone position on ventilator in ARDS. There is no need to withhold feeding. Low albumin is a myth. Do not involve albumin as the assessment for nutritional status. And especially the very important controversy is the actual body weight, ideal body weight, adjusted body weight. A lot of controversies are there. As per guidelines, they use, if you want to calculate calories, they use actual body weight. And especially for obese patients, they calculate 10 to 15 kilocalories per kg as per adjusted body weight. And in ASPEN, they use adjusted body weight, not the actual body weight. So there is a lot of confusion in that. But calories should be calculated as actual body weight, whatever the patient's body weight is. Especially you have to keep a watch when patient is morbidly obese, when obesity is more than 50. Then you have to take care of adjusted body weight, which is actually ideal body weight, plus 0.25 into the difference between the actual and ideal. So it's a very complex thing whenever it comes to bedside management, and whenever it comes to proteins, it has to be ideal body weight. Especially in obese patients, you have to give hypocaloric feed with high proteins, 2 to 2.5 grams per kg of ideal body weight, not the actual body weight. So these are the important things which you need to keep in mind. And last point is, you should not fast a pancreatitis patient. Mild to moderate, start from day 1, and in severe pancreatitis, wait for pain, vomiting to subside and immediately start with at least trophic feed. You should not keep the patient fasting as far as our old age-old teaching was there. So early enteral nutrition is a very important key thing in pancreatitis. Thank you.
A huge thank.
I have a question. Sir, in many of the hospitals, we have seen that they mix a lot of these multivitamins and other supplements to the enteral feeds and it is given to the patient. Whether this is a right practice or we should stop this?
No, it's not indicated at all. Yeah.
Okay.
Yeah.
And for many cases, like for different GI surgeries, they have this old school practices of giving oil-based feeds, which is basically only oils with multivitamins and protein supplement, which is also not.
There are specific feeds for that pancreatic insufficiency patients. So,
Yeah, so
they
that
are
is
there,
also wrong.
digested or digested food, but
Yeah.
If you are giving jejunal feeds, then semi-elemental diet can be given.
Yes.
Others
We are
not.
giving the like formula feedings and other things, but many of the doctors are like, because oil is better tolerated to the GI tract, so they are just giving oils in the GI tract for J feedings and other this in a government hospital I'm talking about. So
not indicated.
yes.
So, when you talk about adding multivitamins, if you are able to feed your patient at least 1,500 calories, all the basic requirements of micronutrients are part of your feed, unless there is a major loss or an increased requirement, as in dialysis. Where there is an increased requirement, you add not to the feed. Okay, otherwise, all the feeds will have, if it is a formula feed, all the feeds will be very well maintained if you're able to achieve 1,500.
Because all polymeric feeds will have all micronutrients in it. Yeah.
Yes, exactly. Nowadays, the ERAS concept, that is early recovery after surgery, where there is a concept of carbohydrate loading and early initiation of the feeding, so that we can use gut more as early as possible and utilize it, utilize the absorption through gut, so that there is early recovery of those patients.
A huge thank to Dr. Rajdeep. There is a saying in ICU that if gut works, use it. But Dr. Rajdeep Chaudhary just showed us that using it is an art in itself. Now I request Dr. Nikhil Balankhe sir to felicitate our eminent speaker Dr. Rajdeep Chaudhary and our chairpersons with our token of love and appreciation.
राजदीप कॉलेज में बहुत फोटो खींचता था, अभी चला गया. We have spent the morning talking about the gut, but as every intensivist knows, sometimes the gut just says no. It goes on a strike, it shuts down, or it simply cannot keep up with the patient's demand.
And that's when we have to bypass the system and go straight to the source. But parental nutrition is not just about hooking up the bag, it's high protective therapy for required careful timing and a very steady hand.
For this session on parenteral nutrition, we would like to invite as expert panelists Dr. Neha Agrawal and Dr. Preeti Jain Badkar. About Neha, she is Managing Director of Neurospine Hospital, Critical Care Consultant. नेहा का अपना हॉस्पिटल है, अपने हस्बैंड को वहाँ काम करने देती है वो. And Dr. Preeti Jain Badkar, she is a Chief Dietitian at King's Kingway Hospital. to guide us to guide us through the when and the what and how of this life-sustaining intervention, we would like to invite Dr. Tushar Pandey, sir. Sir is at present Director of Utkarsh Nursing Home and Consultant Critical Care Medicine at NCI Nagpur. Over to you, sir.
Yeah, thank you and good afternoon to all. I'm going to speak on parenteral nutrition and I suppose till date or till this time everyone has explained that gut comes first. So yes, that's that's a dogma which stands true till date, that enteral nutrition is the best nutrition policy and one should give preference always to gut. But as far as parenteral nutrition is concerned, I guess it is probably misunderstood, underused and misused therapy. So in next 20 minutes, I'll try to get you along with all these facets of parenteral nutrition and we will try to cover the landmark trials during my talk. So I am Dr. Tushar Pandey. I am Consultant Critical Care, National Cancer Institute, and I am going to speak on parenteral nutrition in ICU, what, when and how. At the outset, I'd like to thank organizers for allowing me to deliver this talk. So as parenteral nutrition is concerned, precision is the key. Precision, everything doesn't fits to all. The rule doesn't fits to all. You cannot just write blanket prescription to all the patients. So it is need based. Every patient is different. Every prescription is different. So purposefully I have kept blank on this right hand side of aspect wherein this is TPN bag and the left side of the prescription which is empty, which signifies or which depicts that every patient requires tailor-made approach. The agenda of my talk will be what is pathophysiology of malnutrition in ICU, why parenteral nutrition is needed, when to start, who actually needs parenteral nutrition, how to prescribe, what are the complications and what exactly present day guidelines are. Coming to why parenteral nutrition, it is very well understood till the talk. We have come to know that almost 40 to 50% of the patients presenting to ICU are malnourished. And by the day 3, gut failure makes enteral nutrition, makes them another 30% adds on to the list. So it comes down to 2 to 3 times mortality in ICU as far as severe malnutrition is concerned. And by the end of the 7 days, almost 1000 kilocalorie per day is the gravity of malnutrition, or the patients are calorie deficit almost 1000 kilocalorie per day, and the consequences of underfeeding are quite obvious. There is muscle wasting, prolonged ICU stay, the cost of therapy increases, prolonged ventilation days, and post ICU disability and cognitive impairment. So the key is prevent deficit but without overfeeding. This is a curve which clearly depicts energy deficit accumulation during first week of ICU. This was done. This study was done by Willett et al. And was published in 2005 Clinical Nutrition, wherein on day 1 the darker bottom line. Can I have the pointer, please, if possible? Pointer. Okay. Now. Okay, by the time this is striking trajectory of enteral nutrition only. So by the end of 7 days, almost 5000 to 6000 kilocalorie deficit is there, which amounts to almost 1000 per day. When to start? There are landmarks trial. So EPANIC trial, which was published in NEJM 2010, in 2011, where early parenteral nutrition versus late parenteral nutrition, and they conclude that late parenteral nutrition is preferred. Then there came calorie trial in 2014, wherein they found no difference in in a parenteral versus enteral, but enteral nutrition was preferred. Then came Nutriria trial in 2018, wherein they clearly suggested to avoid parenteral nutrition in early shock. Then there was a debate about protein, the effort protein trial in 2023, wherein high protein showed no benefit and moderate protein target were suggested. And in Nutriria 3 trial, high calorie versus low calorie, isocaloric feeds were having no mortality difference, and they suggested avoid overfeeding. So the key principle here was to initiate parenteral nutrition only when enteral nutrition is contraindicated or insufficient after adequate trial. This EPANIC trial, which was published in 2011 in New England Journal of Medicine, this is supposed to be a landmark trial as far as parenteral nutrition is concerned, wherein this robust N was there, 4,640 patients, and they clearly depicted that patients who received early parenteral nutrition versus late parenteral nutrition, the infections were much less in patients who received late parenteral nutrition. There was less the length of stay in ICU as far as late parenteral nutrition group is concerned, and renal replacement therapy requirement was much lesser in late parenteral nutrition patients. This is a forest plot. The yellow line, which is in between the relative risk, it compares that relative risk early aggressive parenteral nutrition versus the comparator. And EPANIC trial, they clearly mentioned that late parenteral nutrition was beneficial. Calories showed no difference. Nutriria trial said again depicted the same thing, and Nutriria 3 trial, they were not significantly different. So when, that is ICU nutrition timeline, so day 0 and 1, patient coming in shock, it is usually a resuscitation phase. So hemodynamically stabilization is the first and foremost goal. So in that case, we have to avoid all the nutrition. Day 1 and 2, when in early ICU, you can start tropic feeding, permissive enteral feeding if tolerated. Stable phase, advanced enteral nutrition to target, initiate and parenteral nutrition if enteral nutrition fails, and late ICU, full parenteral nutrition. If enteral nutrition is not possible, consider supplemental parenteral nutrition. Who needs parenteral nutrition? So indications for parenteral nutrition are, till now we have discussed a lot, so I just summarize. GI tract, when it is non-functional, inaccessible, there are high output fistulas, severe ileus or bowel obstruction, inability to access GI tract or severe malnutrition, and enteral nutrition is contraindicated, then only parenteral nutrition has to be given if patient is prolonged preoperative fasting and malnourished. And obviously they are contraindicated where gut works, you should not use. Hemodynamic instability, where mean arterial pressure is less than 60 and patient is in shock. Severe hyperglycemia uncontrolled, or hypertriglyceridemia, wherein more than 300 triglyceride level, it is a contraindication to use parenteral nutrition. You have to correct electrolyte imbalance before heading towards parenteral nutrition, and expected stay of ICU is less than 5 days. There is no point in giving parenteral nutrition. Rather, patient can stay bit underfed during those days. An active resuscitation phase, where in parenteral nutrition, or for that matter any enteral nutrition, or even has to be avoided. So the dictum is gut first. It is a principle, gut first always. Enteral nutrition, because enteral nutrition preserves intestinal barrier, it reduces infection, and is always preferred when GI tract is functional. And who requires parenteral nutrition? So there are tools, till we discussed these tools during previous talks, that is NRS and MUST score. The NRS and MUST score are basically for in-hospital patients, while in ICU, a more validated score is M-Nutric score, which includes Apache, SOFA, age, comorbidities, etc. And high score patients, they are definitely going to get benefited by aggressive nutritional support, while low score patients, they are less likely to affect outcome. So preferred tool in Aspen 2022 ICU guidelines is M-Nutric score, and the recent one GLIM score has been now coming into vogue, and people are finding it easy to use. So M-Nutric score versus ICU mortality, this graphs clearly depicts that the bars which are shown in green and left side of the picture, these are of low score. These are the patients who probably will not get benefited by giving aggressive nutrition, while on the right, the red one, the score more than 4, these are the patient we should target. How to prescribe? The principle remains same, 20 to 25 kilocalorie per kg per day. This is for acute phase, say day 1 to 3. Avoid overfeeding, and then from 4th day onwards, one can switch or exceed to 25 to 30 kilocalorie per day. The protein requirement has to be 1.2 to 2 gram per kg per day. This protein requirement should be met, and up to 2.5 gram in burns and trauma patients. As far as macronutrients are concerned, dextrose has to be 3 to 5 milligram per kg per minute, maximum to 7. Start low, monitor blood sugar every 4 to 6 hours, maintain blood sugars between 120 to 180, and lipid emulsions 0.8 to 1.5 gram per kg per day, max one can use up to 2.5. Here in soya, medium chain fatty acids, olive oil and fish oil are preferred because there should be enrichment with omega-3 fatty acids, and hold any lipid emulsion if triglycerides goes beyond 300. Amino acids 1.2 to 2 gram per kg per day. There is increased requirement in burns, trauma, and has to be avoided in hepatic encephalopathy patients. So glutamine, it is not used routinely. So Redox and Signet, these were the 2 trials which clearly depicted that glutamine is not needed in routine parenteral nutrition prescriptions. How it has to be given, I'll run through this. Vascular access, central is always preferred. CVC, PICC, or tunneled, or whatever central line, and it should be a dedicated line for as far as parenteral nutrition has to be given. Osmolar, if you are giving central venous access is not available, if you want to give it peripherally, then osmolality of the fluid should be less than 900 milliosmoles per liter. Short term only, it can be for only short term, it can be used, preferably less than 2 weeks, and there is always a risk of thrombophlebitis. If peripheral nutrition you are expecting to exceed more than 2 weeks, then PICC, that is peripherally inserted central catheter, is preferred. All-in-one formula should be used. All the 3 bags, these are commercially available. Micronutrients can be added, and electrolytes, these depend particularly these electrolytes has to be very individualized depending on patient's need. What needs to be monitored is blood glucose every 4 to 6 hours while giving parenteral nutrition. Then daily electrolytes, sodium, potassium, magnesium, phosphate, calcium, urea, create has to be done. Triglycerides, if lipid formulations are used, and weekly one can monitor LFT, albumin, and weekly weight and fluid balance has to be monitored. Rest vitamins also can be added as per the requirement. What are the complications? And these are real complications which are happening in our ICUs. Refeeding syndrome, the dreaded one. Refeeding syndrome can simply be avoided by using thiamine before starting any nutrition. So hypophosphatemia, wherein phosphate is less than 0.6 millimole. When if you are suspecting, or if a patient is underfed, cachexic, then start parenteral nutrition at 50% of the rate and advance it over the next 3 to 5 days. One has to replace thiamine before starting, and monitor daily the phosphate, magnesium, and potassium. Then parenteral nutrition associated liver disease. It happens because of steatosis leading to cholestasis and then on to cirrhosis. We can prevent it by minimizing dextrose, use SMFO lipid, which is omega-3 enriched, and early enteral transition whenever possible. Hypertriglyceridemia, one has to hold lipids, especially if triglyceride level is more than 300. Restart and reduce the dose when it falls down to 250. The risk of pancreatitis is real. In fact, we had one patient who was post bone marrow transplant, was on TPN for prolonged for Clostridium difficile infection, and then he succumbed due to pancreatitis. So these complications do happen. Then hyperglycemia, it's the most common complication. One has to monitor sugar between 140 to 180. That's a wonderful, nice guideline. Insulin infusion is preferred over subcutaneous bolus doses, and avoid hypoglycemia. Line-related sepsis, that is CRBSI, parenteral nutrition is independent factor. As I mentioned earlier, one has to use a dedicated line for all parenteral nutritions. Nothing has to be mixed with these lines. A dedicated peripheral or a parenteral nutrition lumen is needed. Strict asepsis, hand washing, hub disinfection is needed. Whenever CRBSI is proven, one has to remove, and antibiotic lock and all those stuff one should avoid. Overfeeding causes hyperglycemia, hepatic steatosis, high CO2 production, and prolonged ventilation, requirement of prolonged ventilatory support. So nice sugar trial with N equal to 6,000 odd was published in NEGM, and it clearly depicted that intensive control of blood glucose is not advisable, the red line which is shown in the bottom, and there is always a risk of hypoglycemia if you're targeting sugar too low. So in all for all practical purposes, ICU patient blood glucose target should be 120 to 180. And then refeeding syndrome, the phosphate trajectory. Refeeding syndrome, if patient is malnourished, cachexic, and if one overzealously starts nutrition, then phosphate dips down by 30 to 40 hours to its nadir, and one can have hypophosphatemia, cardiac arrhythmias, and even death. So one has to be cautious and aware of this complication. Start with prior to this, give thiamine and start with 50% of the prescribed dose. This will avoid development of refeeding syndrome. What are the current guidelines? Both ASPEN and ESPN depicts the similar, they echo the similar thoughts. Enteral is preferred over parenteral when gut is functional. And then within 24 to 48 hours, if enteral nutrition is contraindicated, one can supplement in high risk patient with parenteral nutrition. The protein requirement is 1.2 to 2 gram per kg per day. Glutamine, do not supplement. I'll run through this. The special situations, I'll just go rapidly through this. Acute kidney injury, protein, one has to restrict it to 1.5 to 2 gram per kg. There is no, you don't require to go below that. So calories one should meet 20 to 25. Adjust electrolyte as per CRRT. In acute pancreatitis, as we categorically and very prominently mentioned, there is no need to avoid enteral nutrition in even severe acute pancreatitis. So in sepsis, yes, till the time patient is stabilized, one has to avoid all sorts of nutrition. Stabilize first and then start. And burns and major trauma, the protein requirement one has to be very cautious and aware of. So this is practical algorithm. Admission to ICU, assess nutritional status of the patient. If gut is functional, go with the gut. Attempt enteral nutrition 48 to 72 hours. Tropic feed first, and then you can go full-fledged. If enteral is adequate, more than 60% target is met, reassess daily, document delivery, and initiate parenteral nutrition or supplemental parenteral nutrition if your energy goals are not met. So the key points here are always give thiamine before starting any nutrition, or for that matter, now I am speaking on parental. So any parental nutrition, one has to give thiamine. Use ideal body weight instead of actual body weight. Ideal body weight in obese patient, and avoid overfeeding. Dedicated parenteral nutrition lumen only, and measure indirect calorimetry whenever possible. So these are the key takeaways, and a big thank you to all for patience.
Thank you, Dr. Tushar, for that comprehensive overview on parental nutrition. For the audience, if I have to sum up, do not consider parental nutrition as just IV supplemental nutrition. It's a pharmacological intervention which needs to be planned, titrated, and even monitored in a very meticulous way, just like we do for our inotropes or for ventilators. And an individualized concept works very well and gives a better outcome than a blanket one-size-fits-for-all concept. So thank you once again, Dr. Tushar, for judicially covering the what, when, and how of parental nutrition. Thank you.
If patient is already malnourished and his gut is working partially, so when you suggest to start parental nutrition?
24 to 48 hours. If patient is hemodynamically stable, you can start even on the day one. If you are suspecting that patient is malnourished and his gut is not functioning properly, so what is recommended is 24 to 48 hours.
Right. For how many days we can continue that parental nutrition?
Your nutritional goals are met.
Okay. Thank you. So takeaway message is parental nutrition saves life, but we should know what, when, and how. Thank you.
Thank you, Dr. Tushar sir, for demystifying TPN. You have turned what many of us consider TPN as a last resort into a precision tool. It is no longer about if we should use it, but how flawlessly we can use it. Thank you, sir. Now I invite Dr. Deepti ma'am. I request Dr. Deepti ma'am to felicitate our eminent speaker and our chairpersons with token of love and appreciation.
सवाल हम सबके बहुत हैं, लेकिन समय की कमी की वजह से हम ज्यादा सवालों का जवाब दे नहीं पा रहे हैं. वैसे भी एमिनेंट स्पीकर्स ने सभी कुछ कवर ही कर लिया है ना? तो मूविंग ऑन टू आवर नेक्स्ट टॉक, we would first like to invite our expert panelist for the next session, Dr. Piyush Dhawad, Dr. Piyush Kotewar, and Dr. Gargi Rai. Dr. Piyush Dhawad is a physician and critical care practitioner at Saraswati Kidney Care Center. Dr. Piyush Kotewar is a consultant intensivist in LGI Hospital, Nagpur. And Dr. Gargi Rai is dietitian at National Cancer Institute. Now, we have established that nutrition is the fuel in the ICU battle, but sometimes the body doesn't need calories, it needs a specialized defense system. This brings us to immunonutrition. If standard nutrition is the foundation, immunonutrition is the sophisticated software update. But as many of you know, the install hasn't always been very smooth. For years, we have debated these immune enhancing cocktails actually worked. Today, in 2026, the status has shifted from one size fits all to precision targeting. It is complicated yet more promising than ever when applied to the right patient at the right time. But as the latest research shows, the line between helpful modulation and metabolic overload is thin. To help us navigate this current global guidelines and separate the hype from the healing, please welcome Dr. Bharat Jagyasi, who truly needs no introduction, but as we say, protocols have to be followed. Dr. Bharat is Director of Critical Care Department at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is a renowned intensivist with over 18 years of experience in adult critical care and multidisciplinary ICU management. He is also Secretary IACCM Mumbai branch and Treasurer of IACCM headquarters. He is an expert in ARDS, sepsis, ECMO, CRRT, mechanical ventilation. अब कितने नाम लेंगे यार? Dr. Bharat is also a nominee in the upcoming ISCCM elections as for president-elect. Over to you, sir.
Thank you. Thank you for the kind introduction, and thank you, Deepak, for having me over here. And Nagpur, as I always say, feels home because many friends around and many of you around. It's been a great journey being here since many years. I've been coming regularly and we keep meeting. So when we talk of the immunonutrition in the ICU, we have been feeding our ICU patient for 40 odd years, and for 35 odd years we've been discussing whether nutrition is working or not working, hypernutrition, underfeeding, immunonutrition. So this debate is on, but I want to focus today mainly on the very narrow perspective of what exactly is going to work and when it's going to work. So when you talk of the immunonutrition, we need to also understand what does immunonutrition mean. So how does the body reacts? So body has an immune system. We all are aware of, we have the acquired immunity, the innate immunity. So in the initial phases, the immunity is acquired. That is whatever comes in, body will attack, considering all the system will get activated. Then slowly and gradually it becomes very specific. We have the counter regulatory mechanism which comes in play and they go down. So in all that mechanism, what suffers is the gut. Gut is supposed to be the barrier of main thing. So the gut barrier goes away, and in that whole process there's a translocation of bacteria in the portal and the systemic circulation, and this is how the macrophage polarization shift occurs, and this is what we are looking into. But every patient is not same. We are aware of this fact. In the sepsis also, the maximum patients in the ICU are the septic patient, and we all say it's a dysregulated host response. So the response is not homogeneous, it's dysregulated. Some patients will just have a fever, some patients will have hypotension, some will have resistant hypotension, and few will recover, few will die. So even the response is dysregulated, it's not normal, and then how can we have the one size fitting all? So the metabolic catastrophe in the initial stages of hypermetabolism, when you talk of the RE, that is a resting energy expenditure, is almost 20 to 50% more. But do we compensate it early, especially in the trauma patients, burns patients, sepsis patients? The energy expenditure is 50% more than our baseline. And there's also the mitochondrial dysfunction as well. So logically, we should be compensating it. But as Dr. Tushar showed us, we had enough studies. He spoke about the calorie study, he spoke about the apneic study, which tells us overfeeding, especially in the early stage, is going to be harmful. It has worse outcomes. We have to be little smarter in the feeding. So we can't be very aggressive in the feeding. We need to be little smarter when the feeding comes in. And this is where the opportunity comes in of the specific nutrient modulations, where we think those are going to modulate the immunity, and they are going to support us beyond the caloric requirement, and also the targeted pharmaconutrition concept is what overall we are looking into. So this is all about the basics of the immunonutrition, what the rationale of using the immunonutrition is. So when we look into the immunonutrient arsenal, what is there in our armamentarium? So if we look into it, these are the 6 major things what we look into. Glutamine, of course, the mechanism of action we all understand, it's a fuel for enterocytes and lymphocytes, and it targets the gut integrity, its immune cell proliferation. But again, we have the controversial. We'll take it one by one. Then we also look into the omega-3 fatty acids, EPA, DHA, which are supposed to be the anti-inflammatory markers. They will support the inflammation, and especially the inflammatory disease like ARDS, sepsis, immune resolution, they should be helpful. Arginine, there are no precursor, but arginine is very important for the generation of the nitric oxide. This is what we need to understand, and this is why the perfusion gets better, and is very important in the wound healing and the surgical ICU. antioxidants, it could be the selenium, zinc, vitamin C, vitamin D, and we all talk about the redox balance and oxidative stress mitigation. So this is what we look into, and what is coming up now, we're working overall is the probiotics and symbiotics and the beta glucans. So let's take head on one by one. So we talk first of the glutamine, that is the rise and fall of a superstar. So it was very famous in 90s and 2000. We all spoke about it, and the reasoning was, the rationale was, initially they studied any patient who had a worst outcome, glutamine levels are very low. Same is true with the vitamin D3, but it doesn't mean vitamin D3 is a problem. We know everyone's vitamin D3 is low. So whoever was dying, they were measuring vitamin D3, it was low. They related vitamin D3 few years before, it was related to each and every disease. So same was septic patient. Any patient who died, they did a glutamine level. And of course, glutamine is a very good resource of energy. It is required for the lymphocyte and macrophage proliferation. So the initial stages of the critical care illness, it goes down by the 50% because it's been utilized very heavily. And this is why every patient who was dying, glutamine levels are very low. And looking into this rationale, all the guidelines, aspirin guidelines, they started recommending glutamine for each and every patient, considering because the levels are low, we should be using it and it will work well. Same is true with the albumin, as Dr. Shubal spoke about. Albumin is a marker of severity, is a marker of a disease illness. Low albumin doesn't mean patient needs an albumin. So you have to take albumin as a therapy, and same concept came over here. So what changed overall was redox trial, which came in NEGM, published in NEGM in 2013. This was a turning point. Approximately 1200 patients were studied. It was a multicentric trial. And what they found was, when the glutamine was used in the higher dose, it was used somewhere around 0.25 to 0.35 milligram per kilogram. When used in the higher doses, the mortality went up. It was not a negative trial, it was a futile trial. It showed harm. We talk of the negative trial when it doesn't show the benefit, but this was a trial which showed harm, and harm's a signal especially high when the patients were, especially in the renal failure patients, the harm was very high. So then came up the MetaPlus trial, which is a meta-analysis. It was published again in JAMA, which used glutamine along with the omega-3 fatty acid, that is the fish oil. And this also, it showed higher 6-month mortality in the intervention group. So this is why we realize glutamine is very dangerous, is not to be used in ICU. There are certain circumstances like IV glutamine is not recommended in multi-organ failure. Enteral glutamine may be considered in burns and trauma, which is a grade C recommendation by ISPEN, but ideally you should avoid, especially in the renal failure, hepatic failure, and especially when there's hemodynamic instability. This is one of the drugs which is, we've seen it very commonly used, but this is known to increase the mortality. If one of your patient dies and it picks this up, you'll be sued very clearly in the court of law, because there's a very clear mortality over here. It increases the mortality when used in the septic shock patient and the severe critically ill patient. It has benefit. That too, also in oral glutamine has a benefit only in the trauma and the burns patient. So now we take another micronutrient, that is omega-3 fatty acid. So the very famous trial, Omega trial, which came in done by the Rice et al., which looked into the 272 patients. So what's the rationale of the omega-3? So omega-3 is EPA and DHA. So they are the precursors, or they are utilized for producing resolvins, paclitaxins, mastins. What are these? These are anti-inflammatory. So everyone thought if we use omega-3 fatty acid, it is very good anti-inflammatory properties. So if we use in a disease which are due to inflammation, the most commonest is the ARDS. ARDS is an inflammatory response to whatever the disease happens. If we use in those status, maybe it will get better. And this is the rationale which was used, and this is why EPA plus GLA enteral formulas were used in ARDS patient, and Omega trial was conducted by Rice et al., which found no benefit even in terms, not only in terms of mortality, but also in terms of the ventilator-free days, and trial was stopped early. Then came the omega-3 sepsis trial, which was again the 12 RCTs and studied around 1200 patients. They showed in the septic shock patients, there was a trend towards a decreased length of stay and maybe the trend towards a decreased mortality. And this is where the variation comes in. Again, considering both this, the ISPEN came with the guidelines. There's a grade C recommendation in enteral, which has to be used enteral in critically ill patient. And in ARDS, there's very insufficient evidence, we shouldn't be using it. The difference in between the two trial was when we used the ARDS and it was the Omega trial, the glutamine was used in the enteral formulation. So the rationale which also came in, maybe it was an enteral formulation, patients was very sick, absorption didn't came in pretty well, and it didn't work out to be. So in the second trial, which was the omega-3 trial in the sepsis patient, they used the IV preparation, and there maybe they found a trend towards the benefit. So this was the difference in between the two. Now we talk about the arginine. Arginine is a double-edged sword. It's very famous among the surgical patients. Why is that? Because arginine is known to increase the T lymphocyte proliferation. It increases the synthesis of the collagen, and this is a very good wound healing as well. And as he spoke, nitric oxide, it's a nitric oxide precursor. So moment you use arginine, the production of nitric oxide will go up, which will cause vasodilation and increase the perfusion. And this is why the surgical wounds get healed in a better way when we use arginine. But again, it is safe in elective patients, burns, trauma, and wound healing. But what happens in the septic patients? Septic shock patients especially, we already have a vasoplasia. If you use arginine in those patients, nitric oxide production will go up, and your vasoplasia will get profound, or your inotropes won't be effective, your vasopressors won't be effective, and this is why it's more dangerous if we use arginine in a septic shock patients. We have to use in the right context. That is only in the surgical patient it should be used, otherwise we shouldn't be using it. So when you talk of the multiple cocktail of the antioxidant macronutrients, so one is selenium, second is arginine, vitamin C, and vitamin E. So we have the Signet trial which showed when the dose of selenium and zinc was used, especially in the surgical patient, there's less chance of the infection. But here the trend was they measured the selenium and zinc levels in their own patients, and then only they corrected it. They did not use it blindly for each and every patient. So the levels were low, they were using it till you get the normal levels. As we replace potassium in our body, as we replace calcium, we do electrolytes for all our critically ill patients. Once we achieve those levels, we stop it. They don't use very high doses till the levels are normal or beyond those levels. So in certain set of the patients, when there are low levels of arginine, selenium, if you're doing it, you correct it, get those to the normal level, maybe you will have a benefit towards the trend. You shouldn't be using high doses for each and every patient. So this is about those 6 giants of immunonutrition, what we've been considering of. And now what exactly they does. So it's around 20 years back, John Marshall said this: gut is the motor of all multi-organ failure. Why is that? Because if you see, the 70% of our immune system resides in the gut. Why? Because gut has a microbiome. Microbiome trains our immune system. So our immune system gets trained in the gut, and where each and every exposure to different microbiomes, it come up with the different actions, and they are going trained over that. So what happens in the septic patients or in the ICU patients? We continue giving antibiotics, we continue using probiotics, we give antacids. That changes the overall gut microbiome, and that is called a dysbiosis. And because of the dysbiosis, the training of the immune system goes down, and this is why the incidences of VAP, surgical CRBSI, all critical care infection comes in, because our whole immune system goes down, because gut is the motor of the multiple organ failure. And this is the reason why when they introduced probiotics into the system, where the gut microbiome was maintained, they found maybe there's decrease in the incidence of the VAP, that is the ventilator associated pneumonia, with little trends towards the mortality. And the lactobacillus was the one which is the most commonly studied. C. difficile, we all know this. This is where the probiotics reduce the C. difficile infection risk during antibiotics, and lactobacillus rhamnosus is the one which has been recommended, and the grade level A indication, level A recommendation is there for it. And this is why the ECMID has recommended it. But there are safety concerns as well. Especially, we had a trial called as ProCriticare trial, which was done in the acute pancreatitis patient. So what happens is, the moment they use probiotics in the acute pancreatitis, there was increase in the mortality, and the relation to the mortality was because there was a bowel ischemia, more of bacteria, they in a bowel which was poorly perfused lead to overwork of the bowel, and they lead to the ischemic bowel. And this is the reason why they shouldn't be using it when there's a short bowel. They shouldn't be used when there's a shock, because the intestine is not well perfused. And also in the acute pancreatitis, we shouldn't be using probiotics. It will increase the mortality overall. So these are the landmark trials. If you look at the glance, there's an impact trial which is about the arginine and omega-3 fatty acids. So IV omega-3 was better in the post-surgical patient. It was supposed to be reducing the infections. Then we had the redox trial, which was about the glutamine. and we all saw that glutamine was stopped. There was increase in the mortality. And this is one of the trial which shows us glutamine shouldn't be used. The same was true with the Meta Plus also in the JAMA 2014. Then we had the Omega trial where the parental omega-3 fatty acids were used, and they found it there are not really 23 days, and they stopped it. Again, they came up with the next trial which they use the IV omega-3 fatty acid. They found trend towards getting benefit. So these are the various trials which have happened, especially the probiotics as well, permit as well, and calories around the use of micronutrients in the critical care. So glutamine, if you look into the different recommendation, that is by the aspirin and the aspirin, if you look into glutamine, no recommendation in both the groups. When we look into the enteral glutamine, can be used in the burns trauma as per the SPEN groups, and SCCM and SPEN says just replace the deficiency. Omega-3, SCCM, SPEN says not recommended totally, and SPEN says can be used if the patient is taken enterally. Selenium, replace only to the normal levels and prefer to enriched lipids. Probiotics may cause decrease in the VAP prehension, but you shouldn't be using probiotics when the patient is in shock, when there's a short bowel syndrome, or when there's an acute pancreatitis. Arginine to be clearly avoided in the sepsis and can be used in certain set of the patients. Can be used in a certain case of the set of the patients where there's a surgical wound and you need a better wound healing in those cases. So why this heterogeneity? Why major trials have failed? Because as we spoke about, every patient is not same. What we do is we kind of go on with the one kind of the treatment, one kind of a dose for each and every patient. So we have to tailor our thing according to the patient's need. If the levels are normal, correct it. If consider giving potassium to each and every patient, your mortality will go up if you're not measuring the levels. Eventually, there will be many patients who will have hyperkalemia, they will die of bradyarrest. Same true is over here. We don't measure the levels and we continue giving it without realizing higher doses, how they are going to harm us, and there's a total mismatch over here. Concomitant nutrition compounding is basically, we think of feeding always works. Always we know, even if we are vomiting, a mother will come and tell us, no, feed yourself, thoda khale, theek ho jayega, khayega nahi to. This is what we also have a understanding. If we don't feed our patient, they are going to not do well. But sometimes understand, not feeding is also a way of treating them. We have to, it's not necessary to cover the calories always. You can replace micronutrients in a different way and let your patient get stable and feed smartly, not overcautiously or overcautiously. So there are not many metric available to us as these reports regularly. We don't do selenium and zinc and selenium levels on regular basis, and delivery route also varies, and we have to look into this. So the special population, burns and trauma, you can use enteral glutamine. High dose antioxidants, arginine as well for the wound healing. Sepsis, what is the majority of the sets? You can't be using anything over here. No probiotics, no arginine, no IV glutamine, no omega-3 fatty acid. ARDS, IV omega-3 might work, might not work. In elective and surgical patient, again as we spoke, you might replace the oral macronutrients, and arginine might play a role over there. So there's an interesting concept of pharmacogenics, genomics, pharmacomicrobiomics, and myobacter guided therapy is coming in. So when we talk of the pharmacomicrobiomics, as we spoke about, we know gut is the motor of the multi-organ dysfunction. The reason is because 70% of the immune system lies in the gut. This is where it gets trained. So if the overall gut microbiome is displaced or dysfunction, then what we do is they are also looking into the fecal transplant mechanism which is coming in, and especially this is mainly being studied in the cases of the resistant C. difficile infection. And eventually what they will do is they'll phenotype the patient, do the biomarker profiling, microbiome mapping will happen, and when the lactobacillus levels are good, you don't need a fecal transplant, and when the lactobacillus levels are really low, that is the time when you'll need a fecal transplant. The genotypic assessment with a tailored immuno treatment needs to be done. When it goes for the days, if you look into the day one, you can replace with the normal doses of selenium and zinc, start probiotics to prevent VAP if the patient is not in shock and not an acute pancreatitis. Day 3 to 7, titrate to enteral nutrition, continue selenium replacement. Day 7, stabilize, move on to the enteral. But what you need to avoid is glutamine, arginine, omega-3 in all of the patients in all across the day, especially when the patients are in ICU. So individualize, do not cocktail. Glutamine IV is really harmful. Arginine surgical, yes. Septic shock, no. Replace, do not mega dose antioxidant. This is what we continue doing it. And precision is the best future. Thank you very much. Thanks, Akran.
That was a very insightful and detailed discussion regarding topic, sir. Sir, I wanted to ask, what in the studies we showed that there were not major mortality and morbidity benefits. So, baseline monitoring of all the nutrients which were deficient or which were not deficient, would that have made a major change in those studies which were
The
negative?
mortality benefit, there's no mortality benefit over here. What we're looking into the trend, if you ask me the positive of all, positive is arginine in the surgical patients for the wound healing, not in the critically ill patient. If you look into the IV omega-3 fatty acids, it might be working in an ARDS, but we are not very sure about it. Rest all is no. If you have to do it, just replace it and stop it. What problem we have is once we start the trace element, it goes on till the patient is discharged. The patient is lucky if he's discharged in 3 days, it will go on for 3 days. The patient is unfortunately for 30 days with her, it will go on for the 30 days. So this is where we have to refine ourselves. Cannot, this is why I gave an example of potassium. Just imagine giving syrup Kazol to every patient for 30 days. Eventually you have the death. So these also are the drugs we need to consider that way. Give it only when it's required. When you've proven deficiency, replace it. Once you achieve the normal level, stop.
So my questions to you as a dietitian is, what do you think for all these trials which we have, because they don't have they have a lot of methodological limitations. Very small trials are also there to suggest, or a grade C recommendation is also from the ISPN. So is it because of the methodological limitation is there in these studies? That's why it is happening?
What you're looking into is that if you ask me about the omega-3, this is where we are little balanced. Otherwise, trials are very clear. Vitamin C is clear no in the critically ill patient. We had enough trials to say it's not to be used in the higher doses. We had enough trial to say arginine is not to be used in the critically ill patient. We have trial which says glutamine IV is not to be used in the critically ill patients. So I think there's no ambiguity over it. So our thought process, we think that way should be used. If at all you're using in early phases where you feel my immune system is acquired, there's a lot of requirement, use it for a day or two and then stop it. But especially those micronutrients, selenium, arginine combination, not the high
So you
dosage.
feel the time of feeding and the dosage to get the therapeutic effects of these immunonutrition will also be important?
No, eventually, my first slide was that only. We've been trying to feed our patients the last 40 years, and since 35 years, we're finding it the way out. So actually, if you ask me, nutrition does have to play a role in the mortality, but not a very big role in the mortality as such of the patient. It's a support therapy, what we need to understand. You cannot avoid not feeding the patient, but at the same time, in the process of feeding, we don't want to harm the patient. This is what we need to understand.
So for certain cases, like I've done one study on glutamine, which is published.
Enteral or IV?
Enteral nutrition in cancer patients.
Enteral and neutral trials. Enteral are always, if you see all the trials, enteral and neutral trials.
Yeah, so mostly for mucositis induced because of chemotherapy or radiation therapy. So glutamine has some role in that to actually decrease
So
the
what
grading
dose
of
were
the
you using?
mucocyte. It's 0.5 grams per kg body
Per
weight.
kg, right.
Yes. So the dosage is also, when I was doing my review of literature at that time also I was to this point, but then I think what I felt after reading all the meta-analysis is that the timing of feeding when you're starting, in fact for the ERAS protocol also, if they say immunonutrition, so when to start, how to start and how much dose to be given is something which is very controversial, and because of these limitations we don't have a very large trials for that.
Immunonutrition for ERAS protocol is totally a debatable thing. I wouldn't say why was it practiced also. You're doing it for someone who just NBM for 6 hours. Why you want to give? So someone who's fasting today, Sudhir is fasting, please put him on the immunonutrition. Where is he? You're right. So it's that way. ERAS is just 12 hours of fasting and you can't be considering immunonutrition. No, we don't use anything in our ICU. Absolutely nothing. Sir?
See, honestly, it's a big no. Even I don't use it. There are only a few burns patients where certain people, where surgeons really prepare it in burns patient, that too in the initial level of 3 to 5 days. But they are used like a drug. They are always used in the enteral form, not in the parenteral form, not in the enteral form. That way. Otherwise, there are not major indications where they use it. Though they have even recommended in the surgical guidelines of ISPN 2025, which came up, they said that in traumatic brain injury, it can be considered. only in a few subset of patients, provided there is no renal dysfunction, and arginine, as what Bharat said, in surgical patients. That too, in case if we find that it's a difficult to heal wound, those are the subset of patients where we find. Like what you said, even in the enteral form, the redox or the other studies went off because they used both enteral and parenteral. That way.
And because one of the study also quoted that for redox, they are using glutamine with antioxidants. So because there is ambiguity in the ICU patients.
See,
who get
antioxidants
trauma,
are again a
injuries,
big
burns.
plus minus.
Yeah, so because you have a mixed crowd in ICU from all over the places, and they are using and they respond to this certain immunonutrition in a different way. So there is always a limitations on that. So it is not at all recommended. But in certain cases where they have a beneficial effects like cancer, burns, injuries,
In the whole of whole,
Yes.
any adjuvant form of therapy, if you really analyze in the whole perspective of critical care, you see vitamin C, you see immunonutrition, you see any form of adjuvant therapy. All those therapies, they have worked well only if used judiciously within the first 48 hours situation, not later. Not later, not in the end stage as a dire resort, and the patient is going to die, and then you consider to use it, then it's
No,
not
it is
not work.
I completely agree with you, sir, for
Yeah.
that.
So this is also a part of a adjuvant therapy. Immunonutrition did gain very importance. What even Bharat said, the ISPEN 2019 guidelines did had omega when mentioned as a part of protocol for ARDS patients because of the anti-inflammatory action there. But later on, it went down the line.
Yes. Thank you, sir.
Thank you.
The same thing actually happened with Zygris.
Thank you, Bharat sir. Can you please hold the stage, sir? Now I request Dr. Deepak Jaswani to please felicitate Dr. Bharat and our expert panelist. Deepak sir.
So when it comes to the elections, I'll be contesting for the post of president-elect, and along with me, Dr. Kapil Borak will be contesting for the general secretary-elect. So we both are from the Maharashtra and request you to support both of us. Thank you.
I think we can all agree that after that this session, our immunity to confusion has definitely increased the immunonutrition. We have completed full circle of nutritional interventions, from the basics to of calories to brilliance of immune modulation. We are now better equipped with the for the battle, as Dr. Monica has mentioned earlier. Thank you everyone for this for your master class. Now we acknowledge the presence of Dr. Tanuja Manohar, President API Vidarbha Chapter, and Dr. Kumbhalkar Ma'am, Sunita Kumbhalkar Ma'am, Professor, Department of Medicine, AIIMS Nagpur.
All right, everyone. We have fed our brains with a lot of data this afternoon. Now it's time to see how much of that nutrition actually got absorbed, or if it's just sitting there as residual volume. Don't worry, we aren't sending you back to the medical school. We are moving into our grand quiz session. Now I know what you are thinking, Monica, itna to pad liye din bhar. It's been a long day. My brain is hitting a hypoglycemic crash. Well, we have got you covered. In the true spirit of Criticare hospitality, we are not making you move an inch. वो कहते हैं ना, मरीज का लैक्टेट बढ़े तो फिक्र होती है भारी. मरीज का लैक्टेट बढ़े तो फिक्र होती है भारी, पर डॉक्टर की चाय छूटे तो समझो शाम है भारी. क्विज के सवाल देखकर कहीं बीपी ना बढ़ जाए आपका, इसलिए चाय का इन्फ्यूजन है आप सब पर जारी. सबको हम सबकी सीट पे उनकी चाय पहुंचा देंगे. वी विल बी नाउ मूविंग ऑन विद आवर क्विज. थैंक यू वेरी मच. Over to Dr. Shailesh Chokse, who is a consultant intensivist at Intima Hospital, Nagpur.
We are going to start with the quiz. This is a online quiz. You have to enter into the quiz by scanning a QR code or a game pin. And this is very simple quiz.
the fastest finger will be given the highest marks. For correct answer, if 10 people have given a correct answer, out of them who has answered it fast, earliest will be having a more points. So do participate, everyone. It's a simple quiz. Nobody will know your name if you make any mistake. So you can directly put a www.kahoot.in on your mobile, or you can scan this QR code. Once you scan this QR code, you will be he will ask for your nickname. You can write your name and enter into the quiz. Once you enter your nickname, you will be visible on the screen with the name. Or if it is not possible to scan the QR code, you just need to type kahoot.it on your mobile. If anybody is having any issues, I can help them. So ICU Nutrition Mastery TPN Enteral Nutrition Quiz. The first question on your screen. How much total calories should ideally come from protein in ICU nutrition? Option A, majority, more than 50%. Equal distribution among micronutrients. The correct answer is 0 calories. Proteins are used for not for the calorie, they are for the supplement and building blocks in ICU. Out of this, 60 have wrong answer, only 3 have given correct answer. Next. Zain, एक मिनट open कर, एक game pin सांग. The first. So in this, 3 people are correct, Dr. Miraj, Raj and Mr. Kadri. So next question. Presence of vowel sounds is. Not always necessary before starting enteral feeds. The correct answer is given by 27 participants, and so still we are going below 25% for correct answers. So now there is a change in the scoreboard. I think Miraj is on the first side, on the first position. Question number 3. Gastric residual volume alone should with sign interpreted clinically along with the signs of intolerance. So most of you have given the correct answer. Let's see the scores. Miraj is still on the top with the 2,427. He has given 3 correct answers. Next question, question number 4. What does REE means in expenditure? 58 people have given the right answer. So let's see the score. Miraj is still on the first, and 10 participants just hit 3 continuous correct answers. Next question. What is tropic feed in critical care means? Let's see. Wi-Fi is connected. So, I think all answers are not marked. We will go back to the same question again. लिया ना, disconnect हो गया. So again, we need to go to the next questions. I think all participants are in. You lost. You can enter it again with the same. Yeah. लास्ट टाइम मार्कंडेवर टाकलं आता याच्यातूनच मोबाईल कनेक्ट झालं का ठीक आहे बघू बघ सुरू आहे हा all are connected again. मेरा कनेक्टेड है अभी वो वाईफाई आ रहा है क्या all are joining again. Numbers you can put a game pin 39. स्टार्ट करूं क्या 5th क्वेश्चन से रुक जाओ मैं पहले 5 क्वेश्चन हटा के क्विज चालू कर देता हूँ एक डिस्कनेक्ट करूंगा 5 मिनट्स ये नहीं ये इसमें से निकल हाँ नहीं तो स्विच मुझे दिख So I am again starting with the quiz. I have deleted 4 questions. हाँ एक बार फिर से करना पड़ेगा. अभी कनेक्ट कर लो. हाँ. आएंगा अभी. अभी तो सबका एक्सपीरियंस आ गया होगा तो जल्दी लॉगिन हो जाएगा. गेम पिन 3383882. $75, $76. All are entered. So already 91 participants. We are starting with the quiz. Anybody left? Anybody left? Should we start? Presence of vowel sounds. Repeat question, I think. 30 seconds, 20 seconds now. Yes. Now most of you are correct. Yeah. But still fastest finger will win. Next question. What is the osmolarity bit below which TPN can be administered peripherally? Less than 900, only 21 has given the correct answer. So let's see the score. Now PM, I think who is a PM, I don't know, is leading the scoreboard. What is the best method to calculate calorie requirement in critically ill patients? Option A, pain and state formula, Harris Benedict formula, indirect calorimetry, or Mifflin Saint formula. I think all the answers. answer. Let's see the scoreboard. Still PM is leading, Rahul is on the second. Amol sir is the highest climber, up by 28 places. Next, what is the dumping syndrome and where does it typically occur? The answer is neurological, question is neurological complications after stroke, colon dysfunction after restriction. Gastric emptying after gastric surgery. 53 people have given a correct answer. Let's see the scoreboard. Now Rahul has came to the first spot, and Garg is the highest climber, 22 places up. Next, what is the first step in managing repeating syndrome? First step in managing defeating syndrome. Let's see the answer. Preet and Rahul are leading the scoreboard. Next question. Glutamine is a part of immunonutrition, has shown benefit in which condition? Trauma intel glutamine has some role. It is a class C recommendation. Only 31 people are given a correct answers. Scoreboard, Rahul is still on the top. RDB is second and RB is climbing up fast on the third spot. Which of the following is wide site compatible or can be given with TPN? Only 11 people have given a right answer. Potassium phosphate causes precipitation as well as calcium causes precipitation. Chloride, potassium chloride can be given. Let's see the scoreboard. The answer, now the positions has changed. RB is on the first. Next question, a patient is receiving propofol 1% at 5 ml per hour. How many approximate calories does this? Each ml of propofol provides 1 to 1.1 kilocalories. Next question. Which is the most appropriate indication for TPN? One of the indication of TPN from the following. and the correct answer is given by 52 people. Again, the first spot is at the position doesn't change on first three spots now. Let's go to the next question. All of the following are ICU nutrition assessment tools except Nutrix score, COG score, MUST, and SG score. "75 answers, 14 seconds remain, 12 seconds, 11, 10. So the correct answer is ECOG is not a part of assessment score. So PRT is having 3 correct answers on third position. Let's go for the next question. Last 4 questions left to change your positions. Which micronutrients provides maximum energy per gram? It's fats, proteins, alcohol, or carbohydrates. Very simple question, I think. Easiest of all. Alcohol you can take if it is favorite to somebody. Extra glass for them at night for extra energy. So the correct answer is fat. It provides approximately 9 kilocalories. And position remains again the same. Last 3 questions. And the fight is very close between RB, Rahul and Priyat. Only, I think, difference of 100 to 200 only. Which is the main advantage of 3-chamber TPN bag over single chamber compounded TPN bag? Has a long shelf life, provides higher protein content, require daily aseptic compounding, or better nutritional support. Last 8 seconds. Last chance for changing your position. I think there will be 4 winners. So the correct answer is has long shelf life. The answer is correct in 17 people only. So the position now is Rahul is again on the top and the RB gone down. Simsum as on the second, RDB on third, SDM on the fourth, and the fight is very close, I think. Let's go to second last question. Patient is in the immediate post-trauma period, have low cardiac output, low oxygen consumption and hypothermia. Most appropriate nutritional strategy would be immediate post-trauma period, low cardiac output, low oxygen consumption and hypothermia. High protein, hypercaloric diet, full calorie feed, aggressive parenteral nutrition or minimal or tropic feed. Last 10 seconds. Last 2 seconds. And the correct answer is minimal or tropic feed. I think 57 people have given correct answer. Let's see the position. Now again, Simsum is on the first, RDB on 2, Rahul on the third position. And up, Arshia is moving fast on the 15th position. The last question for your position to confirm. Patient is immediately after major trauma, shows low cardiac output, decreased oxygen consumption and hypothermia. Metabolic state is best known as anabolic phase, catabolic phase, F phase or flow phase. Last 5 seconds, 4, 3, 2, 1. The correct answer is F phase. It is given correct by only 28 people. Let's see the position and the winner of this quiz. The third position is DK with 9833 points. 12 out of 14 are correct. SDM position 2. SDM I don't know. And the first is Simsum with 10,600 points. 12 out of 14 are correct. So congratulations to Simsum. The fourth position is of RDB.
Who is RDB?
RDB.
RD Burman?
RD Burman कौन है आखिर?
Two dietitian,
You are
two
RD.
nutritionists and two doctor will be.
ऑडियंस से पेपर लीक होने की खबरें बहुत आ रही है, इसलिए मैं अपना पोजीशन सरेंडर कर रहा हूँ.
RDB is a nutritionist.
Anybody who is nutrition.
You are a
physician.
इसको देते हैं.
Symptoms.
Simpson.
अरे सिमसम को निकाल दे यार.
No Simpson.
SDM. Who is SDM? Okay. You are a dietitian, nutritionist or physician. Rahul.
No Rahul. No Rahul.
RB.
इनको दे.
Yes. Nutritionist, ma'am.
Yes. वो दोनों physician को दे. ये मैडम डायरेक्ट nutrition दे.
PR. Who is PR? PY.
Ban.
Preet. Who is Preet? Preet, physician or student of nutrition. So she will be the fourth. Do. So to both of you and ma'am, and please come on the stage. Thank you, sir. I think everybody has enjoyed it.
Awesome, Shailesh, awesome.
It was a technical glitch.
Winners, please stage की तरफ प्रस्थान करें.
आइए.
The important part of the days following right after. We have the practical workstations ready for you.
We have set up specialized workstation where you can interact with the experts, see the latest internal and parental setups and clear those on-job doubts. Please, you can join the station.
हम दोस्तों को अलग नहीं करना चाहते थे, आपस में अलग अलग 3 ग्रुप्स में बैठ जाइए प्लीज. Stations are there, so audience please get divided in 3 groups and you can rotate between those 3 groups.
सर और मैं सर पिछले 6 साल से इंटर्नशिप या प्रैक्टिस भी नहीं कर रही हूँ. फिर भी सिर्फ मेरे को मिला बता.
के लिखा बैग दिखाया उठा ले.
right. The second table is on the right of the audience and the third table is in the back of the room.
तेरे को पहले ही बोलती चिट्ठी बना, सुनते नहीं है मेरी बात। एंट्रल वाला है नहीं, वो एंट्रल है सर। और वो क्या है? हाँ चलो हम वहाँ कॉर्नर पे जा रहे हैं, वो लास्ट वाला, वो लास्ट वाला। अरे दिलीप सर को बोलो ना बांटने के लिए। बोले मैं बांट दूंगा, सब बाहर जा रहे हैं मैम। वही तो मैं बोल रही हूँ, इसलिए तो बोल रही हूँ ना। क्या बोलो?
Audience, enteral nutrition. First, 1/3 of the audience, enteral nutrition besides the stage. These are specialized workstations where you can interact with the experts themselves. So 1/3 of the audience left of the stage, 1/3 of the audience, parental nutrition is on the right of the audience seats, and the prescription for nutrition is at the back of the hall.
दो मिनट समायरा को ना बहुत जोर से लग गई, उसका पैर हाथ ना गाड़ी में दब गया, बहुत जोर, बहुत रो रही है। लेकिन अब क्या करूं, मेरी बेटी का, छोटी वाले का।